Okay, with that, welcome to Health and Human Services, and I open the first bill, which is Senate Bill 561, and invite the prime sponsor, Senator Ricciardi. Welcome.
Good morning, everyone, Madam Chair and members of the committee. My name is Denise Ricciardi, and I have the honor of representing New Hampshire's Senate District 9, which includes the wonderful communities from Bedford all the way up to Hinsdale. I am pleased to testify as the prime sponsor of Senate Bill 561 relative to prior authorization for health care. Over the past several months, I've been working with sponsors of this bill and healthcare leaders from across the state, including representatives from the New Hampshire Hospital Association, the New Hampshire Medical Society, America's Health Insurance Plans, the New Hampshire Department of Insurance, to draft legislation in response to these concerns. I hear from my constituents about their challenges with prior authorization. While prior authorization can help ensure medical care is necessary and appropriate, it can also be an obstacle to necessary patient care when providers must navigate complex and widely varying payer requirements or face long waits for prior authorization decisions. This bill will remove barriers to patient care by streamlining prior authorization timelines and requiring meaningful transparency of prior authorization requirements on insurers' websites. The bill codifies into New Hampshire statute a clear peer-to-peer process for providers to engage with a clinical peer from their patient's insurance carrier for a direct exchange on the basis of the prior authorization request. The bill also requires carriers regulated by the New Hampshire Department of Insurance to report on prior authorization metrics in line with a new federal rule from the Centers for Medicare and Medicaid Services. As I noted, this bill is in direct response to concerns from my constituents. Too many Granite Staters are left in limbo, waiting for approval from their insurance company to move forward with important medical care. This bill enacts a reasonable timeline for carriers to make a prior authorization determination in line with federal timeline regulations. This will allow the New Hampshire Department of Insurance to enforce timely prior authorization decision-making on the health insurance plans it regulates. This bill breaks down barriers to make it easier for doctors and nurses to provide care that people need to stay healthy. Finally, although we have not had a specific study on the expected savings from this bill, by enacting efficiencies and streamlined prior authorization process, 561 should put downward pressure on insurance premiums and the cost to provide care. A recent rule from CMS that includes many of the same provisions in Senate Bill 561 estimates the rule will result at least a $16 billion in savings over 10 years and a reduction in provider burden of at least 220 million hours over 10 years nationally. In closing, I would really like to thank all the stakeholders who worked with me and other sponsors of this bill to bring forward a compromise amendment that is supported by both providers and carriers. In working with these stakeholders, it is clear to me that all parties involved advocate in the best interests of their patients, their members, and all of our constituents. Thank you for the opportunity to introduce Senate Bill 561 to this committee, and I'm happy to take any questions.
Thank you, Senator. Any questions from the committee? Seeing none. Thank you.
Well, thank you very much.
Representative David Nager. Welcome.
Thank you, Madam Chairman. Thank you, members of the committee. I'm going to just start my testimony with a number. I'm going to say 15 billion, and I'm going to explain what that means at the end, keep you in suspense. I'm David Nagel. I'm a representative. I've been here for about a year now. Relative to this bill, though, more importantly, I'm a physician, an advocate. I've worked for the rights of patients and their providers now for over 30 years. This issue is near and dear to me. It's so important that when I wrote my book, Needless Suffering, and published in 2016 in the chapter of healthcare reform. There's a whole section on prior authorization reform. Senator Ricciardi basically stole an awful lot of my thunder, so I'm going to simplify, but this issue has been extremely important to me for a long time. It's been one of my campaign promises to get this addressed. I'm very honored to have taken a leadership position on this, and I'm really happy and excited and to have worked with a multi-stakeholder group to develop this bill. What I think we need to also include when we think about that is this is not just about doctors, it's not just about healthcare providers, but we included anybody that a prior authorization applies to. That includes chiropractors, physical therapists, and other people. And going forward, as hopefully we include other providers into healthcare, integrative care, they will be included as well. As we also think about this issue, I think it's really important that we keep our mind on two separate principles that are very important. I believe that we have a healthcare system in distress. I think the prior authorization, the way it's evolved, is a symptom of a healthcare system in distress. The most important thing that we do, both as a doctor and as a society for a patient, is to remember that the doctor-patient relationship is critical. Anything that interferes with that is a problem, and whenever we create public policy, we need to always think about what the potential adverse effects on that may be, unintended or intended. The other issue that's very important and really near and dear to my heart is I'm a dinosaur in New Hampshire. I'm a private practitioner. There's not many of us left. When healthcare reform started 30 years ago, 80% of doctors were in private practice. Now the number is less than 20%. And I think it's critical that we preserve private practice because that solves a lot of the problems that we see in healthcare, and anything that adversely affects that, such as the way prior authorization process evolved, needs to be addressed. Let's see. Going forward, I think you also should know that when we started this process, it was very important to me to be as inclusive as possible. And I'm just going to give you the how. We can talk about the why, and Senator Ricciardi kind of already did, but basically what we wanted to do was get feedback from everybody in developing this bill. So when we started, we convened town halls of chiropractors, doctors, and whatever, and we came up with a laundry list of problems. I also speak all over the country on these issues, so I've talked to doctors and providers all over the country, so we had a pretty good idea of what the concerns were. In doing that, we finally realized that the AMA had already created a template for us. And so what we did was we looked at what our issues were in this state, what the AMA has said, and that's how we started to create a bill. I was honored to find out that Senator Ricciardi was working in parallel with us, and then we joined forces, and she's a genius, and she put together the idea that we should reach out to the other side. So we reached out to the insurers, and by working together, we were able to come up with this bill. And what's even more exciting that you should also know is that 2 weeks ago, CMS just released their statement on prior authorization reform, which basically says the same things that we did in an 800-page statement. The reason I said $15 billion is that that's the money that they expect private practice to save if prior authorization reform goes ahead as planned. In summary, it's a bill that was created by nonpartisan, multi-stakeholder cooperation and support that I'm incredibly proud to be a part of. It has the potential to cut healthcare costs, preserve private practice, improve access to care, improve efficiency of care, and improve communication between stakeholders that mirrors federal efforts, and that is absolutely critical. While it's not perfect, and I will not say it's perfect, it is certainly a start, but this is what I'm most happy about is relationships have been created that this can be an ongoing discussion and we can continue to work on this. And I'm happy to take questions.
Thank you, Representative. Any questions from the committee? Seeing none. Thank you.
Thank you very much.
Michelle Heaton.
Good morning, Senator, members of the committee. For the record, my name is DJ Betancourt, and I have the pleasure of serving as the Commissioner of the New Hampshire Insurance Department, and I am joined this morning by my colleague, Michelle Heaton, who is one of the unsung heroes of the amendment that you see before you. It is with a great deal of pleasure that I am able to join you today in support of Senate Bill 561 as the amendment proposes. It is rare for our department to take a position on legislation that was not requested by the department, but this is an exception for the reasons that I will explain. Before I cover the details in the compromise amendment, I want to credit Senator Ricciardi and Representative Nagel and all of the stakeholders who came together to advance important reform to the prior authorization process. They did so collaboratively, and they did so in good faith. The amendment before you represents the best of what New Hampshire's legislative process can and should deliver for the citizens of our state. In terms of the details in the amendment, I think we can all appreciate that prior authorization is a key pillar in our managed care system. It not only helps to control costs, to promote affordable premiums for consumers, but it ensures that consumers are getting quality of care, high quality of care at the most appropriate setting to ensure best health outcomes. That said, I think we can all appreciate that prior authorization has its flaws and has issues that need attention. As with any system, if you want to preserve the overall system, and I do believe that prior authorization should be preserved, then you have to be prepared to bring appropriate reform from time to time. And that is where this amendment comes into play. As Senator Ricciardi mentioned, it does four predominant things. First, it addresses wait times. It addresses the turnaround times with deadlines to ensure that access to care is not needlessly delayed or held up. Second, it deals with prior authorization reviewers and the qualifications of prior authorization reviewers to ensure that on the one hand, the system is not bottlenecked, but also ensuring on the other that the individual reviewing the prior authorization request for an insurance carrier is appropriately qualified to render an appropriate judgment on the care that is being sought. I think we can all agree that it is not helpful to have a prior authorization individual who is a podiatrist reviewing the prior authorization for someone seeking care for a cardiac issue. This amendment straightens out that situation. Third, it establishes very clearly what I call the pre-prior authorization peer-to-peer review, such that if a provider is looking at what he or she believes is a particularly complex case, and one that because of that complexity raises the likelihood that it is going to be rejected or delayed, that provider can reach out in advance to do a peer-to-peer discussion to make sure that everybody is clear on the details, the complexities are worked out, and that process for prior authorization can go faster. And finally, it brings transparency and accountability in the sense that the carriers will have to provide the insurance department with data around prior authorization, and that data will be made public. And we will have that either on our department's website or our health cost website once that provision is fully in effect. I will just end by saying that when we started this journey, I did not think we would find ourselves in a place today where we're all moving in the same direction. But as I said, I think the work that has gone into this is a testament to the New Hampshire spirit of coming together, working collaboratively, and advancing substantive reform for the betterment of our state. Michelle, is there anything you'd like to add?
No, but I'd be happy to answer any questions about any technical aspects of the bill.
Thank you. Any questions from the committee?
Okay.
Oh, Senator Bradley.
Thank you very much. There's been a lot of discussion, as you know, Commissioner, about prior authorization, in particular for mental health. We've made a number of reforms. So this continues that process. That's good news. When you come and testify in front of the legislature, you and your predecessors always talk about upward pressure on rates. Are you concerned about that here?
No.
That was the answer I wanted to hear. Thank you.
Any other questions from the committee? Commissioner, if you can you stick around till for exec?
Certainly.
Okay, thank you. See no questions. Thank you.
Thank you.
Ben Bradley.
Good morning, Madam Chair and members of the committee. My name is Ben Bradley. I'm the Vice President of State Government Relations with the New Hampshire Hospital Association, one of the many stakeholders that has come to the table for this bill and amendment. The Hospital Association is very supportive of SB 561 relative to prior authorization for healthcare. We've been involved in these discussions since the beginning in the fall of last year and appreciate the leadership and collaborative work of Senator Ricciardi, Representative Nagel, Commissioner Betancourt and his team, Ava Hawks from the New Hampshire Medical Society, and representatives from the New Hampshire insurance industry to draft a solid bill and amendment for the committee's consideration. I'm not going to get into details of the bill because I think that's been laid out by other speakers before me, but our members have shared concerns about the effect of prior authorization on delays in patient care. We believe this bill is a step forward, will reduce costs in New Hampshire's healthcare system, and ensure healthcare professionals can devote more attention to caring for patients. We're deeply appreciative of the sponsor's commitment to these efforts. The bill is the result of many hours of stakeholders coming together, negotiating a path forward, which all parties, including carriers, have come to agreement. We request the committee adopt the proposed amendment and recommend the bill ought to pass as amended. Thank you for the opportunity to speak.
Thank you, Ben. Any questions from the committee? Seeing none. Thank you. Heidi? Welcome.
Good morning, Madam Chair and members of the Good morning, Madam Chair and members of the committee. For the record, my name is Heidi Kroll. I work at Gallagher, Callahan, and Gartrell, and I'm here today representing AHIP, which is America's Health Insurance Plans. We're the trade association for the health insurance carriers here in New Hampshire. I want to sincerely thank Senator Ricciardi, Commissioner Betancourt, and his staff, and all of the stakeholders for everyone's hard work and collaboration that got us to this amendment. It took a lot of time and effort, many meetings, and lots of drafting, especially by Alex and Michelle at the department. But we all came to the table and we worked through it, and we now have a Ricciardi special. And as you've heard me and the carriers say on many occasions, utilization management, including prior authorization, plays a very important role in managed care. Prior authorization ensures that patient care is consistent with the most up-to-date evidence-based practices. It helps lower a patient's out-of-pocket cost. It prevents the overuse and misuse of care, as well as potentially harmful care, and it triggers additional care coordination services for the patient. And I think this amendment does a good job to ensure that these benefits of prior authorization will continue while also addressing the interest of the sponsor and the providers who are also at the table. As you heard, in mid-January of this year, CMS finalized its latest rules on prior authorization to streamline the process, and the timing was very helpful in that the stakeholders here were able to sync up key provisions of the New Hampshire proposal with the federal proposal. So I think this will be very helpful to providers and carriers alike in standardizing common practices. For example, as you've heard, we've aligned the turnaround times for using prior authorization decisions with those in the federal rules. We've also aligned with moving toward greater use of electronic prior authorization, which the CMS rules ultimately require both carriers and providers to ultimately move toward electronic prior authorization to improve efficiency and streamline the process. So with that, I would be happy to answer any questions, and I appreciate your time here this morning.
Thank you, Heidi. Any questions from the committee? Seeing none.
Thank you.
Ellen Hartford? Welcome.
Thank you so much for Thanks. Um, I'm Dr. Alan Hartford, recently retired from Dartmouth-Hitchcock, where I practiced for 20 years as a radiation oncologist. I was chair of the department for more than 10 years, and then its founding program director for its established residency in radiation oncology. During that period of time, I treated more than 3,000 cancer patients in New Hampshire and Vermont. And I come here as a patient advocate today and wish to say thank you for, I think, a very good amendment and a good effort and a good bill. There are two major issues which I think it addresses, which are very important. One is the issue of timeliness. Being here in one of the 13 original colonies, it's a little dangerous to mention British royalty. But King Charles, of course, recently was diagnosed with cancer, and he started his treatments the next day. So delay in cancer care is a very important issue. Delay in all kinds of medical care, very important issue. Obviously, the more life-threatening, the more important. In past experiences with utilization management, specifically prior authorization, there have been multiple times where I've been in a peer-to-peer discussion, and the answer was, after the discussion, and the question of medical judgment comes up and what the alternatives are. The reviewer, also a radiation oncologist, says, I agree with you, but I can't approve it. So the effort of getting the peer-to-peer, so quite often taking 2 or 3 weeks, getting everything established and all that, then takes time, and then you end up at the end of that discussion having gotten no farther and the cancer patient being delayed in care. I don't think this is necessarily a conscious issue within the insurance industry, but bureaucracies being bureaucracies and having established procedures, they can trip over the details. So this does address the issue of timeliness and does so very nicely. And I speak very, very heartily in favor of that. The other issue is really that of what I'd call, this is a bit of an impolite phrase, but cookie cutter medicine. So the idea that one size fits all, and you have a certain standard for this particular condition, and this is what you're going to do. It doesn't work quite that simply. And I, as an advocate for my patients, sometimes have to say, well, quite often people would think about it like this. But in your situation, because of X, Y, Z, we need to think about it like that. The most extreme example, I had a patient who had a prostate cancer and ended up having to go through all kinds of tiers in utilization management, ended up being scheduled to speak with the Medicare judge in the state of Florida. And this is under Medicare, so not private, but the same principles. And at the end of the day, after literally weeks of trying to push this particular case, when the materials were all presented and I pulled them all together and then put them out there, the opposing party did not show up in front of the judge. So they found in favor, but I mean, the cost to the healthcare system and the cost to yours truly, the physician, in terms of time and effort and energy to get the right answer was huge. So wanting to be timely, I'll wrap up, but thank you very much. I do hope that meaningful peer-to-peer, which is the effort in this bill, will indeed result, and we'll be anxious to see how this all plays out. Thank you.
Thank you, Doctor. Any questions from the committee? Thank you. Nancy Biederman? Welcome.
Thank you. Nancy Biederman. I was just appointed to the Rare Disease Advisory Council I'm the parent advocate, but I'm speaking for myself and not for the council today. I have 2 children that have chronic illnesses, and to say the least, that I have been fighting insurance companies and prior authorizations for the past 20 years is just been my life. My one daughter, I have a type 1 diabetic, and her insurance company decided to change the insulin that she was using. And you would all think, well, insulin is insulin. It's not. Her doctor fought as hard as they could. I fought as hard as I could, but unless it was going to be life-threatening, they would not let us keep with the insulin that she had been using since she was diagnosed. When the insulin, she had to change insulin, it caused a lot of havoc because it did not react the same way as her prior type of insulin. She had blood sugars that were out of control. She had to put in different carbohydrate numbers into her pump. And with all of those changes in her blood sugar going up and down, it was causing damage to her body. And people are like, oh, no, it's not. Yeah, it is constantly. Her blood vessels were being destroyed little by little. So they used to think children, when they were diagnosed with type 1 diabetes, that they kind of got to skate free until they were adults. They're finding out, and they found out that no, children need to be just as controlled as adults. And by switching this insulin because of money, they've caused damage to my child that we cannot reverse that damage. My other daughter also has a chronic illness, and she gets severe migraines. And she also, her body just doesn't follow the rules because she has a rare disease. And in order for her doctor to get her to a device that would just be worn externally and she wouldn't have to take medication, she had to fail 3 medications. And during that time of failing those 3 medications, she went through horrible side effects. It didn't matter what the doctor said and said, look, I'd like to just go right to this device. The insurance company said, no, you have to fail these 3 medications first. So my daughter was literally tortured until she could get to the external device, which could control her migraines. I was also fortunate with being on the Rare Disease Council to go to New England Rare Disease Conference down in Rhode Island this past last year. And there is a term that I learned that just about broke my heart. It was lost to care. There were stories from other parents who had lost their children to care because of prior authorization and rules from the insurance company. They could not get their child what they needed because their child had a rare disease. It's hard enough when the doctors have a disease that everyone knows about. But when it's rare, it's 10 times harder to find a doctor that even knows about it, let alone knows how to treat it. But then they have to go fight prior authorization from an insurance company provider that's never heard about it or only read about one paragraph in some book somewhere. I will invite you to come on February 22nd. We will be in the State House cafeteria, and we will have a table with information. We have a report card that just came out from NORD, which is the Rare Disease Advisory Council nationwide. We're doing well in some areas. We've gotten some A's, but unfortunately, we're doing poorly in others, and we've gotten some F's. And those are some areas that we, as the Rare Disease Advisory Council, we are working with you and our legislators to get those F's up to at least a B, which would be nice. And that's my testimony. Thank you.
Thank you, Nancy. Any questions from the committee? Seeing none. Thank you.
Support this bill. Thank you.
Jake Berry. Welcome.
Thank you. Good morning, Madam Chair, honorable members of the committee. My name is Jake Berry. I'm the Vice President of Policy at New Futures. As many of you know, New Futures is a nonpartisan, nonprofit health policy and advocacy organization. We've been working for more than 25 years to increase access to quality, affordable health care in our state. I don't want to repeat too much of what's been said this morning, but I do want to stress New Future's strong support for this bill. As you've heard too often in our healthcare system, prior authorization is a source of confusion and consternation and ultimately serves as a roadblock to patients accessing the care they need when they need it. We appreciate the work of Senator Ricciardi, as well as our friends, the insurance department, the insurance carriers, and everyone else who has worked on this bill and this amendment. Yes, certainly the determinations for prior authorization should be made in a quick and timely manner so that patients and providers can get on with developing a plan of care to address the patient needs. Yes, these individuals who are reviewing prior auth claims should be consulting medical colleagues to ensure that determinations are made based on medicine, science, and the patient's best interest. And yes, data and metrics should be available tracking determinations on prior auths. This will increase transparency and accountability. It will give providers, patients, insurance, and regulators the information they need to ensure that patients have access to the care they need. Once again, thanks to everyone who's been involved in putting this bill together. We hope that, and looking out for the patient's best interests, we hope that you'll pass this bill, and I'm happy to take any questions.
Any questions from the committee? Seeing none. Thank you. Right now, the last speaker is Ava. Welcome back.
Good morning, Madam Chair, members of the committee. I will do my best to be as brief as I can. I will say I have testimony that's being circulated that is from the president of the Medical Society, as we are in strong support of this bill and the Replace All Amendment and all of Senator Ricciardi's work. So if the chair will indulge me, I'm just going to do a brief introduction of my testimony. And I should have said this, I know the rules. For the record, my name is Ava Hawks, and I am the Director of Advocacy for the Medical Society. So if the chair will indulge me, I'd love to just read my introduction briefly and then read Dr. Boylan or President Boylan's testimony into the record. And thankfully, I'm a fast talker, so it'll go quick. Okay, alrighty. The New Hampshire Medical Society strongly supports Replace All Amendment 0526S to Senate Bill 561. As I noted, I'll keep my introductory testimony brief. As you will hear today from providers, or as you have heard from providers, carriers, legislators in both the House and the Senate, and patients and parents of patients, the prior authorization process in New Hampshire is just not working. Through a recent CMS ruling that reforms the prior authorization process at the federal level that Dr. Nagel or Representative Nagel spoke so eloquently to, reform that is estimated to save physicians and their practices an estimated $15 billion with a B over 10 years, according to the U.S. Department of Health and Human Services. There is also recognition at the national level that our current prior authorization practices are just not working for our providers, for our patients, and for carriers as well. The Medical Society is immensely grateful to Senator Ricciardi for meeting the moment and tackling this reform in a collaborative way that works best for New Hampshire. Collaboration, some folks, as you've heard this morning, have characterized as making the impossible happen, bringing a diverse group of stakeholders together, as my friend Ben Bradley from the Hospital Association shared, Commissioner Betancourt and the department, and our friends at the carriers. We've worked really hard over the last 4 to 6 months to come up with this compromise language before the committee. And that's attributed to the hard work of Senator Ricciardi. So I want to make sure I highlight that. I will say, too, if you ask our members and the physicians of this state if they feel that this bill or this amendment is just a blanket ultimate fix to the prior authorization process and just completely reforms what we need fixing, they'd say no. But they would also say that we are hopeful, they're hopeful that this is the beginning of what Senator Ricciardi has said throughout this process is the first bite at the apple of reforming a broken system. And so we look forward to that collaboration moving forward. And since I am before the Health and Human Services Committee and before jumping into President Boylan's testimony, I feel like I have to make note that since the Honorable Senate President sits on this committee, this is a really prime example of the work that Senator Ricciardi's done on this bill as a Bradley special, as the term we've all known to come and love, and she definitely duplicated those efforts here. So I feel like I have to highlight that. And so before I conclude my testimony and jump in, I just want to say we support the bill. We support it as amended with the Replace All Amendment, as it would ensure providers, patients, constituents can continue to be served in the ways that they need, when they need it, by codifying timeliness standards and deadlines for carriers, intentional guardrails, and clear guidelines for criteria that carriers expect providers to meet when submitting prior authorization requests, and this promotes transparency and communication among all stakeholders. And I will jump right into Dr. Boylan's testimony. Thank you, Madam Chair. For the record, my name is Maria Boylan. I'm a practicing family medicine physician at Elliott Hospital, and I'm the current president of the New Hampshire Medical Society. The New Hampshire Medical Society strongly supports Replace All Amendment 0526S to Senate Bill 561, legislation seeking to reform the prior authorization process in New Hampshire state law. As a family medicine provider, I care for nearly 2,000 patients, providing a wide range of healthcare services from prescribing medications, ordering labs and imaging, referring to specialty providers and beyond. And historically, family medicine providers frequently encounter the struggles and breakdown in the current prior authorization process in our state, breakdowns that ultimately create significant barriers and delays in patients receiving the necessary and appropriate health care they need. Last month, I feel it's important to highlight a recent example of how the current state of prior authorization delayed access to care and how such delay could have truly had detrimental, even life-threatening consequences for a patient. Last month, I saw an otherwise healthy patient for a routine physical, and during the exam, I noticed a new heart murmur. For context, a heart murmur can be a sign of a heart abnormality or a problem with the heart valve, and the only way to diagnose is with an echocardiogram or an ultrasound of the heart. While this patient had no other signs or symptoms of heart failure at the time of my exam, I felt it was necessary to order an echocardiogram. Like countless providers who provide direct patient care, we must often use our days off as our window to appeal authorization denials for our patients. And for this particular patient, I spent an hour and a half on the phone, was transferred to 4 different representatives before getting the opportunity to schedule a time at a later date to chat with a peer physician to advocate on behalf of my patient. The following week, my patient's order for an echocardiogram was approved. Now that the service was approved, my patient could then begin the actual scheduling of this procedure. And ultimately, it turned out that my patient had a severe valve abnormality and required immediate treatment and surgery by a cardiologist. Had my patient's condition gone untreated much longer, they would have quickly gone into heart failure. Every day, physicians and healthcare providers in our state do their best to provide quality care to their patients, all while navigating the aftermath of a global pandemic, a workforce shortage, and unprecedented levels of physician burnout. Legislation such as Senate Bill 561 seeks to provide real solutions to very real problems, as you've all heard today, and how our healthcare providers in the state have historically had to engage and communicate with the carriers when advocating for their patients' healthcare needs. In addition to being patients yourselves, you have likely at some point in time been impacted by this broken system that has been in place for years. I'm certain that you have also had family, friends, loved ones, and constituents who also have been adversely affected by this process. With the passage of Senate Bill 561, the legislature has a unique opportunity, one where providers and carriers alike agree on such measures as a path forward to provide a much-needed fix to this area of our healthcare system. While many providers, including myself, feel that we have ways to go in truly reforming the prior authorization process, this legislation, coupled with recent changes made at the federal level through a recent CMS ruling, which is in the footnotes of your document should you want to read that, is a good first step in promoting transparency and communication between carriers and providers. The New Hampshire Medical Society thanks Senator Ricciardi for sponsoring this important legislation. We appreciate the bipartisan and bicameral support of this bill and the diverse group of stakeholders who worked for months to bring this language forward in the Replace All amendment before you. For these reasons, the Society encourages the Senate Health and Human Services Committee to recommend ought to pass as amended on Senate Bill 561, an important step in reforming the prior authorization process in our state, a reform that will undoubtedly directly impact the ability of providers to care for their patients across specialties by streamlining this process and removing unnecessary barriers to care. Thank you so much. And I'm happy to take questions.
Thank you, Ava. Any questions from the committee? Seeing none.
Thank you.
Is there anyone here that would like to speak on Senate Bill 561 but was not given the opportunity? With that, I will close the hearing on 561 and we'll go into the next bill as soon as Cam is ready. With that, I will open the hearing on Senate Bill 560 and bring up the prime sponsor, Senator Chanley. Welcome.
Well,
Thank you. Good morning, Madam Chair, members of the committee. My name is Shannon Chandley, and I serve District 11 in the New Hampshire State Senate. I come before you this morning to introduce SB 560. SB 560 is a study committee bill. It came to me sort of late in the filing period. There were others who were interested in seeing this bill move forward. I agreed to bring it to to have the bill filed. It sets up a study committee to look at PBMs. And we know that there is a long and complicated history of PBMs. The pharmacy benefits management is something that we have seen a number of bills over the years, including a number of study committees, I believe, to look at and try to see how to best manage them through our state. I ask you to agree to this study committee, and I would like to just point out something that if you do choose to use this bill, I know once it's in your hands, it's your hands to do with what you wish, but I would suggest a committee amendment that would simply remove the quotation marks on lines 15 and 17, because I didn't catch that until after it had come out. But I don't think that we should be putting the word savings nor the word clawbacks in quotation marks. I think that that presumes a conclusion, which the study committee is actually going to be charged with looking at. So I just ask that you do that. Otherwise, there are other folks here who can speak to other reasons why this should be moved forward, and I'd welcome them. Thank you.
Thank you, Senator. Any questions from the committee? Seeing none.
Thank you very much.
Senator Susie, welcome.
Thank you, Madam Chair, members of the committee. For the record, I'm Donna Susie, representing Senate District 18, and I'm one of the parties who came to Senator Chandley late in the process and asked her to sponsor the bill. In part because PBM issues have traditionally come before the Commerce Committee, we assumed it would go there, but we're happy to be here with all of you today. I'm sure a few of you looked at the bill and said, another study on PBMs. I, for one, have a file drawer full of PBM-related studies, pharmacy-related studies. But what I will tell you is that this is a rapidly changing industry. It is a very, very complicated industry. I think many of us know as we've tried to work our way through the system. But on each study committee that I have served regarding pharmaceutical issues, new information has come to light that's caused us to enact legislation that I think would benefit consumers. One of those I would highlight that did come to light, given the previous hearing that you heard testimony on, was prior authorizations regarding medication, particularly medications for those experiencing a mental health crisis. Many of us did not realize that it was a challenge for many psychiatrists and psychologists who tend to be sole practitioners, not group, to do the kind of backup needed for the PBM to ensure that the individual could get the medication. So that led to, which was very different than a lot of other practice areas where they practice in groups, they have more administrative staff to deal with those issues. That led us to do the prior auth legislation that put a finite amount of time by which the PBM had to make a decision so that in instances of emergency, somebody could get an emergency supply and the decision would be made quickly for the safety of the patient and for their family. So I give you that example to say, although this looks like another study of the same thing, it really is not. The industry is changing. Every time we do these, we do gain more information, and I think the information that we gain helps us make more educated decisions that benefit patients and consumers. So for those reasons, I would ask you to please vote out to pass on this bill, and I'd be happy to answer any questions.
Any questions from the committee? Seeing none. Thank you,
Thank you,
Senator.
Madam Chair.
Representative David Rochefort?
Thank you, Madam Chair, members of the committee. For the record, my name is David Rochefort. I represent Grafton 1. I live in Littleton, New Hampshire. I want to thank Senator Chanley for bringing this piece of legislation forward this year, and I want to reiterate exactly what Senator Soucy has just said about a rapidly changing environment. Looking at my experience, I'm a pharmacist. I've been a pharmacist in New Hampshire since 1997, and I venture to say I'm probably one of the only legislators here under this roof that have ever signed a contract with a PBM. And the contracts we were signing in 1997, 1998 are much different than the contracts we're signing. My last contract I signed was 2 years ago when I last owned a pharmacy. And the point I think that's important about a study committee, and I want to focus really on the value of the study committee, is this is a rapidly growing, rapidly evolving industry. And I think if you sit there and you think about who your doctor is, who your pharmacist is, if you watch television, you're going to know probably the names of more drugs than you ever wanted to. But the reality is PBMs have a huge role in the delivery of medication. And most consumers don't understand that. And if you walk into a pharmacy or receive any type of medication, the PBM will be involved, whether you know it or not. And it was my experience here legislating, even before I was elected, working on pieces of legislation, there's the committee would serve to educate not only members of the committee, but any legislation that would come out of the study committee. And I think it would be a more practical, a more transparent, a more comprehensive approach if this body or the body on the other side of the wall actually decides to go forward with legislation. Findings of a committee would serve that well based on the scope of this. So I would ask that you would support this. I think it would be good. It would be a good step, and it would provide everything that Senator Soucy and Senator Chanley had said.
Thank you for your testimony. Questions from the committee?
Thank you.
Seeing none. Well done. Curtis? Welcome.
Thank you, Mr. Chairman. Good morning, members of the committee. My name is Curtis Barry, here on behalf of the Pharmaceutical Care Management Association, known as PCMA, which is the trade association for the PBM industry nationally. I've got two documents being handed out, which I'll go over shortly. But I checked off neutral. PCMA does not have a position on a study committee bill. In fact, I would suggest that I, on behalf of PCMA and PCMA itself, would welcome any opportunity to explain as often as we can the benefits of the PBM industry, the PBM services to the business sector, and how PBMs save employers and those sponsoring the plan, whether it be the commercial sector or otherwise, save them money so that they're able to provide a more robust benefit for their employees. But I'll make a few comments. The first document that I gave you is, you've heard that there were other studies over the last 13 years. That's a portrayal of the various studies that have been conducted. We participated in them thoroughly. In addition, and I understand it's strictly limited to the public sector, but there's the Prescription Drug Affordability Board. Representative Merchant, who's here, chairs that currently. The second document I think is important. Senator Soucy mentioned it's a complicated industry, and I would suggest further than that, pharmacy reimbursement is a complicated process. On the right side of the document, the chart, the infographic, if you will, portrays the reimbursement where the PBMs are involved. On the left side, however, is an important piece of the leg of this reimbursement that's often forgotten. On small e, under the duties of the study committee, impact of PBMs with respect to retail pharmacy pricing decisions. I suggest there's a lot more that goes into that than just the PBMs, including the manufacturers and the wholesalers. how much are wholesalers charging the retail pharmacies? I suggest that that should be a subject of the study committee as well, in addition to the manufacturers, which I know the committee has heard me mention before. A couple of the pieces on the duties of the study committee. Small c going up, PBM's use of clawbacks that the sponsor referenced. Clawbacks were the subject of legislation in 2016, currently in 3 sections of the insurance statutes. The same, I believe it's the same language, 402N:4, 415:26, and 420J7B. If we want to look at it again, that's terrific, but that's already been covered in statute in what I recall was an agreed upon section. I think, Madam Chair, that concludes my comments. Again, we're neutral on the bill and look forward to participating in the study.
Any questions from the committee? Seeing none. Thank you, Curtis. Last speaker on this is Gary Merchant. Welcome. I'm sorry, Representative. If I'd known you were a rep, I would have brought you up sooner.
Thank you, Madam Chair. For the record, my name is Gary Merchant, a representative of Sullivan County, District 6, proud towns of Claremont and Croydon. Also, a past president of the New Hampshire Board of Pharmacy and the current chair of the Prescription Drug Affordability Board. I come before this committee in full support of this bill. There have been many things that we've done in the State House and the State Senate over the years. So why now? What changed? Fundamentally, a key reason is that until the Supreme Court, through unanimous decision in December 2020, Rutledge versus PCMA, PBMs were governed, if you will, solely on ERISA, which put most plans and so forth outside of the scope of a state law. However, with that decision, upholding the Arkansas state law, saying that ERISA applies to the plan design, not the financial benefits of PBMs. Today, prescription drugs are close to 20% of the healthcare dollar. It's becoming unbearable for many of our fine citizens in our state. And we have to think about what's causing the rise. If you listen to the manufacturers, they'll point to PBM saying they're taking all the rebates and therefore the prices are going up according to them. Listen to the PBMs as saying we're saving all kinds of money. I don't know which one's telling the truth. Maybe they both are. I don't know. But I think we need to find out where it's going. Number 2, do PBMs interfere with the marketplace? Are they really a level playing field for all the players, or are they using unfair competition to interfere with market competition, which is the foundation of our society? A free market provides the opportunity to lower cost. But if we don't have free and fair competition, we don't get there. 3, you heard earlier in Senate Bill 561. Are prior authorizations actually helping or hindering? Are they getting involved with clinical care? Are they deciding things clinically and not the physician, not the provider? I have a report I'll hand out to you folks, if I may. This is from our neighbors next door on the other side of the Connecticut River, who have done comparable to what we're doing here. It's a 115-page report. I didn't want to burn too many trees today, so I only provided with you folks the first 3 pages. However, I will gladly provide any senator the link to the 115-page report if you so desire it. And probably most importantly,
Representative, I think we can do without.
you can do without it. Thank you. And also, when you have a study committee, trying to find people who want to sit on the committee can be arduous at the best. I will tell this committee and the folks on the House side, if it makes it over there, I'll be more than glad to sit on the committee to serve. So that's my story for today. I just think it's a timely issue for us to think about PBM and look at it before we figure out what to do about it. If we don't understand what the problem is, it's hard to write legislation. So all this is really doing is helping us to solve or try to understand it. Thank you.
Thank you, Representative. Any questions from the committee? Seeing none. And apparently I lied. There is one more speaker. Stephen Kavidas. Sorry about that, Stephen.
Am I on? Thank you for letting me speak today. My name is Stephen Cavadias. I am a pharmacist and an owner of a retail pharmacy. I am in support of this bill for many reasons, but I think the biggest reason is transparency and patient outcomes. What we are seeing in our industry today, and it has drastically changed just since the beginning of the year, is that we are on a path that is unsustainable for any industry. My concern is with this bill, I support it. I would like to participate with it. I would like to be able to provide data, input as much as I can. However, we need to add one more component to this, which is patient outcomes. Patient outcomes are being affected because of they're not being able to get the care that they need. We've heard this over and over and over again today. However, this is a component that is huge and has the biggest return on investment, both fiscally and socially. So I am here. Everyone has spoken elegantly about why this is needed. I think this is something that should be ongoing and not just a one and done thing, because things change. So I am here to answer any questions that you may have, and I would make myself available at any time to help with this cause.
Thank you, Stephen. Any questions from the committee? Seeing none. Thank you. Is there anyone here that would like to speak on 560 that was not given the opportunity? With that, I will close the hearing on Senate Bill 560. And when Cam is ready, we'll move on to the 407. Hold on. Chris Lemieux, you signed in support but not speaking. I don't know whether you want to speak or not. Okay. Senator, I will open the hearing on Senate Bill 407 and welcome the prime sponsor, Senator Prentice.
Good morning, Chair Burzilla, members of Senate. Health and Human Services. For the record, my name is Sue Prentice. I'm the state senator from District 5, representing 15 communities in large part of Grafton County, communities in Sullivan County, and one in Merrimack, the beautiful town of New London. I am here today to introduce Senate Bill 407. This bill, as introduced, would require commercial insurers to pay ambulance services directly for their care and transportation provided when the patient is covered by and paying for that coverage from a health insurance plan, regardless of in or out of network status. At the outset of my testimony today, or my introduction, I would like to thank, as you know, I've heard this morning others coming to the table to talk about the collaborative nature of the work that's being done within bills that are before this committee. I've worked on pieces and parts of this with the Department of Insurance, with AHIP, with the different payers. Although we're not exactly where we need to be, the great part about this is that the lines of communication are open. And I will agree with Commissioner Betancourt completely that Michelle Heaton is an unsung hero at the Department of Insurance. She does great work for us. So with that being said, Groundhog Day was last week. But for me, Groundhog Day is today, because I am pulling out a copy of a study report on this very issue from 2018. So we have, and I'm going to refer to it later in the recommendations that were made, but it did state in this report that since 2009, the problem of insurance carrier reimbursement for ambulance service has been discussed in the New Hampshire legislature. So again, I have some recommendations from this report I'm going to share with you later, but this is not a new issue, but I believe the time has come, and I'll explain why. As it stands today, if you call for help, you are transported by an ambulance and you have commercial insurance coverage, the payment for that service often goes to the patient, not to the provider of the ambulance care, unless that service is in that payer's network. So this is often not all, but enough, and that's why we're here. And I'll let the different ambulance services and organizations that want to speak to this talk about how that impacts them. At the time you dial 911 or you need an emergency, an unscheduled transfer to tertiary care, so that is a higher level of care at another facility, either in New Hampshire or in Boston, potentially Maine or Vermont, that status of whether you're in or out of network should not be considered. The closest, most appropriate service that meets that level of care to transport that patient is exactly what we should be serving, what we should be considering from a medical perspective. So I am only speaking at this particular moment to emergencies, but I am going to add in here, because it is encompassed in the bill that's currently introduced, that we also have a situation where non-emergency, so those are scheduled transfers that are moving patients in between hospitals, moving them to skilled nursing or to other more specific care, are impacted by this problem as well. And we may hear from representatives who want to talk about that. So and it's difficult for me because of all the work we've done together to characterize this way, but there seems to be an unwillingness or an inability to pay these ambulance services directly, regardless of network status, which has resulted in putting the patients in the middle because they're getting the check and then have to make a disposition with this check, or creating a gap in revenue that's left to the taxpayers to cover. The EMS system in New Hampshire is not unlike the rest of our nation. It is struggling. Reimbursement is a key contributing factor to the impending failure of our primary care safety net, which is emergency medical services. In order to do the work, we need sustainable wages for our personnel, safe transportation vehicles, and yes, we do need state-of-the-art equipment based on the level of care that service is providing. That's what you would want for yourself, your family, and any residents in this state. This is just like when we're talking about how hospitals prepare themselves, their equipment, that we are, even though we're doing this in different environments, there is an equality that is there. Without aligning reimbursement, including paying ambulance services directly for the work done, we are allowing a mounting pressure and creating lost revenue. Even in 2009, the study report recognized that the then current reimbursement system, including not requiring direct pay, are contributing to lower pay in a competitive market. And now in 2024, we're facing an even more exacerbated workforce shortage in emergency medical services. I'm going to give you two very recent examples. One is, so in Lebanon Fire Department in the city that I proudly live in, and my husband retired from that department after 30 years, there was a structure fire in our neighborhood last Friday. So you could see the fire 2 streets down from our house. The fire department using the mutual aid system, so bringing in other communities as well as staffing with their own ambulance, was managing that fire, and there was an additional medical call. In a city like Lebanon, one of 13, we get an additional medical call, and the dispatcher puts out the call for help. There is no ambulance that's available in Lebanon. Then they ask for mutual aid, and they are unable to secure an ambulance to come into Lebanon to care for this patient. So the fire chief, because the situation was enough under control, took the ambulance service that was standing by to care for anybody who might be injured at that fire scene or a firefighter and deployed that to the other medical call. So we are already seeing signs of this. Secondly, I'll refer you to a Boston Globe article on January 30th, and although this speaks to an out-of-state incident, I think it's worth noting. Winthrop, Massachusetts contracts with 2 ambulance services. Those 2 ambulance services are tied up. They have an additional call for help. It is a child in cardiac arrest. Okay? They are unable to secure a mutual aid ambulance to come and transport that child. So the fire chief does the right thing. He takes his 2 EMTs, the child, they get in his fire chief's Suburban, and they proceed to a Boston hospital. This fire chief used this opportunity to talk to talk to the press about this was a tragic situation, but a cautionary tale of where we're at. So he used this opportunity to talk about the things that we need to do to improve staffing, to take this workforce shortage, which we hear all too much about in healthcare, and put some fixes in place, or this will not end. So there are 2 very recent real-time examples. So we can fix this. We can protect the patients. We can take them out of the middle, and we can close this gap in revenue that's now being covered by taxpayers. Time and time again, I've heard from different payers, again, who are very collaborative in our work, we just haven't been able to get there, that the practice of not paying an ambulance service directly is being used as leverage, a carrot and stick approach, to entice that ambulance service to come into network. Clearly, it's not working because this has been going on for years. And honestly, I don't think that it's fair. I think it's discouraging, but I do understand that they're trying to create network adequacy, but at what immediate cost to their beneficiaries who are paying their premiums. Secondly, I hear that ambulance services can balance bill. So you want direct pay, but you're not prohibited from balance billing. That's true. We currently aren't. And we've talked about this at this committee before, but I'll just quickly roll through this again. We know that the No Surprises Act at the federal level has prohibited balance billing in all but emergency medical services. It's temporary, not permanent. In that legislation passed, Congress established a 17-member, either 15 or 17-member committee under CMS to write the recommendations for Congress on how to bring emergency medical services into the NSA, so to prohibit balance billing. I was named as one of the members of that committee and have spent countless hours in the last year and a half. The recommendations that will go to Congress are done. The 3rd draft has now been signed off on. I can't tell you what they will or will not agree to, but what I can tell you is the argument of they can balance bill, well, that window is closing, and it's going to close within, if not the next year, I think it's more likely 2 years. This should not be a reason to continue to have this discussion. So I have prepared 2 amendments. They're not before you today. As I explained to the chair, I'm still trying to work some different sides of this to maybe bring some more consensus and get support across different stakeholder groups. But one of the amendments that I'd like to bring in, and again, not today, they literally just came back from OLS, would specify how the minimum qualified payments would be set and would give respect to the municipalities, the entities, whether they are directly municipally related, they are direct municipal agents, or they are contracted by how they set their minimum qualified payment. I think that that's an essential conversation and is being addressed in the EMS work for the No Surprises Act. The second would be establishing a commission that would and that could, in a time-sensitive manner, develop our own, join 12 other states in the nation, and develop our own No Surprises Act for emergency medical services. This is certainly something I have spoken about with Commissioner Betancourt. So I am holding on those so I can finally review them and bring them to the committee and continue to work with what I believe are a robust group of stakeholders that I credit the Department of Insurance with bringing together over the last, well, since this last summer, which has been very helpful. So I want to just point out two other pieces. One is that most recently it was signed in November, but was being prepared for signature in October. The state of New York, the governor signed this bill and put direct pay into place. And I read a quote in the Journal of Emergency Medical Services that came from a stakeholder that said, and I'll share it with you now, no matter if an ambulance service provider is in or out of network, reimbursement for every response will come directly from the health insurance company. Patients are no longer forced to be the middleman in a broken payment process that oftentimes has left the ambulance service out. I thought Indiana, the state of Indiana, passed a bill, I believe it was last week, to do just this. The study report, again, starting back from 2009, but this is in 2018, it makes 3 key recommendations, and I'll make sure that you all have copies. Boy, what digging you have to do on our advanced bill search to find these things, but I managed to get there. Recommendations. One is deleting the phrase, which currently is in statute, that the check is payable to the insured and the ambulance service. Instead, it says that that for provides the medically necessary ambulance services shall be reimbursed directly by the provider. I'll actually read this for clarity. In each insurer that issues or renews any policy of group or blanket accident or health insurance that constitutes health coverage under RSA 420 G2 and that provides benefits for medically necessary ambulance services shall reimburse the ambulance provider directly. It strikes the line or by check to the patient or putting both names on it, subject to the terms and conditions of that policy or plan. Secondly, it encourages the Department of Insurance to continue discussions centered on network adequacy for ambulance service and methods for negotiating better rates for ambulance services. And it's good because we actually have been doing that. And third, it encourages staff at the insurance department to explore methods for determining the scope of the problem of balance billing for out-of-network emergency ambulance services. So 2 of the 3 are well in play, but the direct payment is not. Lastly, and I'm going to wrap up here, I have, and I will give to Cam to share with you, I got an email late last night from the fire chief in Littleton, New Hampshire. I'm not going to read it into the record, but what he was able to do was go through all of their, basically all of the bills that haven't been paid for folks that have commercial insurance, and they keep a running tally of this, track down which ones the patients were paid, because they actually call them and they find out the patients have been paid, and those patients have not reimbursed the town of Littleton's fire department-based ambulance service for that work. Over the last 18 months, that mounting total is $54,242. The city of Lebanon, where I live, I spoke to the fire chief this morning. I'm like, why didn't I call my own fire chief? In 2023, he pulled this number alone. That number's $13,313. I think there are more stories of this. So you should also have in your email a letter from the Professional Firefighters of New Hampshire expressing their support for this legislation. The New Hampshire Fire Chiefs I know are represented here today, as well as the New Hampshire Ambulance Association. And I can't thank all the different stakeholders, including the payers. We might not agree, but we are really working towards go. Thank you for your time, your consideration. I'll answer any questions that I can. If not, I'll defer to some of the experts in the room who are much better at this than I am. Thank you.
Thank you, Senator. Senator.
Thank you for your
Senator
testimony, for doing all your homework, and we appreciate it. I was just kind of going over the methodology in this, and it talks about, the check is issued, this bill removes language permitting reimbursement via check issued to the insured and provider and mandates direct payment to the ambulance, like you're testifying. But it talks a little bit about specific negotiated rates. And it says, and the new language directs insurance to reimburse ambulance providers at specific negotiated rates. In the absence of a negotiated rate, the insurer will be required to pay the usual charge.
Usual customary. Yeah.
Right.
Correct.
Reviewed by the insurance department. Now, no surprise in you're saying something about no surprise in billing, but could there be a surprise in their premiums?
So thank you for the question. So I am bringing in an amendment to this to clarify, because, so first of all, if you're in network, the rates are negotiated between the ambulance service and the payer. Those negotiations are confidential. Okay, so that is an agreement that they make. Outside of that is where we have the issue where the payments are going to the payers. Now, usual and customary, it's the initial language I used with Senator Avard in considering and continuing to work on this. The reality is that the usual and customary might not even come close. So usual and customary is more of a like global, regional, what's traditional, to what it costs, say, the town, the city of Nashua, who contracts with their service, or the town of, say, Hollis, who has their own service, what it costs them just to do the job of putting that ambulance service on standby and responding to calls. So that inconsistency I need to clear up with this amendment. And I know that we'll hear from our, well, I can't say that I know, but I've, been the conversations about a correlation between the raising of the premiums and paying people directly. I still haven't, in my opinion, I haven't seen that really line up. I know that it's an argument, but I'd also like to point out that I pay my premiums, others pay their premiums. So these people that are using the ambulance services have already paid their premium to have that service covered. So let's pay the service that did the job for them and keep them whole so they can continue to do the work.
Thank you.
You are welcome.
Senator, I just have one question. On the Indiana.
Yes.
Did it pass one body, both bodies? Where is it in the process?
I am going to check. I have an email on that. I believe that it's passed the House and not the Senate.
Yeah.
Okay. But I actually have the language.
Okay.
Okay. And if I'm incorrect, I'll let you know.
The other question I have, and it may be more for the providers, why are the patients getting the checks?
Because so the patients are getting the checks for, as I understand, two reasons. One is that there is a statute that exists that is actually, there's a bill that's addressing this in the House that says that you pay the patient and the ambulance service. Now, you put both of their names on the check, but what we know is both of their names are not ending up on the check. And in fact, it shouldn't be both of their names. It should just be who provided the service. So that is one. And then as I shared during my opening remarks, as I understand this, in order to bring ambulance services into network, to entice them in, this is being used as leverage. So that's why it's not going directly there. And let me state that if we could get more providers in network and we could create network adequacy, we could solve a lot of problems for the interfacility transfer side of this, which the hospitals may speak to, or I'm sure they've signed in favor of this, but we're not going to get people into network with this standoff. It's just not working. So I think we have a two-pronged approach, and that's what I want to bring forward in my amendments. I hope that helps answer your question.
Any other questions? Seeing none. Thank you, Senator.
You're welcome. Thank you.
Brooke Belanger. Welcome.
Good morning, Madam Chair and members of the committee. My name is Brooke Belanger. I'm the Vice President of Financial Policy and Compliance at the New Hampshire Hospital Association. So I can briefly speak to interfacility transfer as well. I'm here representing all 26 of the state's community hospitals, as well as all specialty hospitals. NHHA supports SB 407 relative to direct pay for ambulance services. First and foremost, ambulance services are a vital component of our healthcare system, providing immediate and life-saving care during emergencies, as well as provide essential supports to our hospitals in conducting critical and time-sensitive interfacility transfers. These dedicated professionals work tirelessly to ensure that individuals in distress receive prompt medical attention, often in situations where every moment counts. However, the current reimbursement model can pose challenges for both ambulance providers and patients. Implementing direct pay for ambulance services would streamline the billing process, leading to quicker reimbursement, allowing ambulance services to allocate valuable resources more efficiently and maintain the high standard of care our communities deserve. Patients often find themselves navigating a complex web of insurance claims, creating unnecessary stress during an already stressful and challenging time. They don't always know that the ambulance service hasn't been paid or don't know what to do with the check they've received from the insurance company. Moreover, supporting direct pay for ambulance services aligns with the broader goal of enhancing sustainability of emergency medical services. Adequate reimbursement is crucial to maintaining the availability and quality of ambulance services and ensuring that our communities continue to receive the best possible care during emergencies. I urge you to support this bill, which will in turn recognize the critical role that ambulance services play in saving lives. And I'll provide a copy of this. I will note it says my colleague Ben Bradley on this, so I'll have you follow up with him for other questions, but happy to answer anything right now.
Thank you, Brooke. Any questions from the committee? Seeing none. Thank you.
Thank you for your time.
Michelle Eaton?
Hello and good morning. My name is Michelle Heaton and I'm the Health Law and Policy Legal Counsel at the New Hampshire Insurance Department. I'm not going to get into the particulars of the bill that was filed because I understand that Senator Prentice is looking to do an amendment. So until we have those particulars, I don't think it'd be worth the time to delve into it. But I did want to give you an overview of what the insurance department has been up to. So our insurance commissioner had, when he became commissioner over the summer, had been receiving a lot of calls about this issue, balance billing for ambulances and some of the financial troubles some of these ambulance providers were having. So he convened some work groups that started over the summer and went through the fall. During these stakeholder meetings, we were attempting to find consensus on balance billing. We were specifically focused on the role of commercial health insurance when considering the overall funding of ambulance services. We wanted to address, one, the problem of surprise billing or balance billing to patients for people in the commercial insurance market. Two, the problem of establishing a more rational, stable, and equitable funding mechanisms for ambulance services and the role of commercial health insurance in those rational systems. And three, the problem of inefficiency in the current service system and the opportunity for improved service delivery models. Everyone agreed that ambulance providers are vital to emergency response in communities and an integral part of the health system. We were able to identify some common ground on a number of issues. There was agreement that ambulance providers need adequate funding to ensure that they can provide the necessary services when called upon. There's also agreement that the current emergency transport system is inefficient and that better delivery models ought to be available. Although there was very little support for the idea of balance billing, ambulance providers were generally loath to tackle the issue in isolation without also solving the overall problem on how best to fund emergency transport services. The overarching policy issue that prevents stakeholders from reaching any further consensus is where the funding for these services should come from. Some argue that communities should decide what emergency services will be available within their communities, and is it appropriate for those communities to cover any funding gaps with public funds. Others argue that the commercial insurance market should be paying an amount adequate to cover the costs of providing the services that are not covered by Medicare and Medicaid. It is important to note that only about 20% of all transports involve commercially insured patients. If commercial insurers are required to pay significantly higher fees to compensate for other payers like Medicare and Medicaid, who some argue are not paying enough, then the cost of funding emergency services gets shifted to consumers purchasing commercial insurance. This philosophical divide regarding who should be responsible for funding emergency services in community is a major obstacle that prevents stakeholders from working out any further details about how to address this important issue. From the department's perspective, we deem the primary issue is the need to protect consumers from balance billing for ambulance services, and we strongly urge policymakers to include that prohibition on balance billing in any legislation they consider. Now, during our stakeholder meetings, there are some important things that I wanted to highlight that we discussed. Medicaid rates for ambulance transport have historically been very low and about half of what Medicare pays. Last year, the legislature increased the Medicaid funding to allow an increase in rates for ground ambulance. Starting in October of 2023, Medicaid began reimbursing ground ambulance at Medicare rates. That will provide additional funding to these providers. There are also different market dynamics and service delivery challenges involved with scheduled transports versus non-scheduled transports. Non-scheduled transports generally refers to emergency transport, whereas scheduled transports typically involve facility-to-facility transfers. The claims data shows us that the amounts being billed for facility-to-facility transports are consistently higher than for emergency services. Non-municipality ambulance providers provide almost all of these services and typically charge significantly higher mileage rates. There are also funding disparities for emergency services across municipalities. Some communities have made the decision to fund their emergency services at higher levels than others. While most municipalities only cover emergency transport, there are also some municipalities that provide non-emergency or scheduled transport as well. The needs of the community can also vary widely, depending on whether the area is rural, urban, or super rural. So those are a lot of the issues that we brought up in our different stakeholder meetings. We are in the process of drafting reports summarizing all of our findings and some of the recommendations the department has come up with. There's just a couple things I want to touch up because they had already come up in conversation. With respect to direct pay, currently carriers are not required to pay providers directly because they are not in network, and there is no contractual relationship between those out-of-network providers and the insurers. Because there's no contractual relationship, the carriers are allowed to pay the patient directly, and the patient is still responsible for paying that out-of-network provider. So that was one thing I just wanted to clarify a little. We've also talked a little bit about coming up with a usual and customary rate or some kind of community rate. The only concern the department would have with that is that we would say that there should be some kind of cap. Because if you don't set a cap, then the rate that is usual and customary or the rate that the community decides is going to be their rate could be a lot higher than where it currently is at. And the concern with that is that that could drive healthcare costs up, and in turn that would drive up premiums. So those are just two of the few points I want to highlight, but I'm happy to answer any questions.
Thank you, Michelle. Senator Hagbard.
Thank you, Madam Chair. You brought up balance billing a couple of times. How does this bill affect balance billing, or does it not, or should we consider that in our deliberations?
So I believe as currently written, there is no prohibition on balance billing. And what the department would urge is including that prohibition. So currently, the way the system works is that if a patient receives ambulance services from an out-of-network provider, that out-of-network provider would bill the insurance. The insurance is going to cover what they think is at an appropriate rate. That is pretty much never the billed amount, which the billed amount is the rate that the ambulance provider charges. So once they receive that insurance payment, and glossing over the whole direct pay issue, but there is that gap between what the insurer thinks is the reasonable rate and what the provider is charging. Currently, that provider could then bill the patient for that difference in rate, and that's what we call the balance bill. There is nothing in law currently that prohibits providers from balance billing for ground ambulance services. And we think that is the key to any reform that needs to happen. It's to take the consumer out of this issue and come up with some system. And that's where I think there's a lot of disagreement about where the funding needs to come from, who should be paying it, and what that commercially reasonable or appropriate rate is. And that's kind of where things start falling apart.
Thank you, Madam Chair. So does this bill, so we didn't want the patient to get a surprise billing. This doesn't necessarily protect them from that then?
No, currently as drafted, there is no prohibition on balance billing in the bill.
Two. Thank you very much, Chair Birdsall. And once again, thank you, Michelle, for being here, for taking my question. So would it be fair to say that when a check arrives directly to a patient, not to an ambulance provider, and then they have the responsibility for that we're actually putting them in the middle on whether they're going to pay the ambulance bill or not?
Legally, they're responsible for the payment of it. But yes, the current system, the patient is in the middle, both for the direct pay and for balance billing situations.
Correct. And that's the second place that I'm going to go. Based on my testimony and conversations that we've had, is it your understanding that the ambulance service exclusion in the Federal No Surprises Act is temporary? That's question number one.
Technically, the way the law is written, for it to be temporary, Congress would need to take an action. So there's nothing in the current law that will cause a springing prohibition on this in the future. It's going to take a new act.
So secondly, if I may, is it fair to say, or is it your understanding that in the No Surprises Act, that exclusion for emergency medical services directed CMS to establish a committee to write the recommendations for Congress to prohibit balance billing?
Yes. The intent of the No Surprises was to create the study committee so that they could address ground ambulance separately than all of the other services that were prohibited from balance billing under the No Surprises Act.
That is correct. And it is as we've heard, the complex nature of the delivery models throughout the country. But is it fair to say that the window on balance billing is closing, and that either the work at the federal level or what we take up at the state level will take that argument off of the table as it applies to direct pay?
I would agree that it's an issue that everyone's working really hard on, but there is nothing that is waiting for the president's signature or the governor's signature at this time. So when that happens and the time frame for that, I don't know. I think, like you said, we've been working on this issue for a long time. So
is it fair to say that there's a prohibition of balance billing that is coming? We just don't have a time frame exactly on whether it's state or federal. The feds are going to do it.
I hope it's coming.
It is. Thank you.
Any other questions from the committee? Seeing none, thank you, Michelle. Chris Stagwatz? From Hollis. Welcome.
From Hollis. Good morning, everyone. My name is Chris Awaz. I am a resident of Hollis, New Hampshire, and I'm here representing the New Hampshire Ambulance Association. I'm also the Regional Director for American Medical Response, which services the communities of Nashua and Manchester in New Hampshire. Thank you for the opportunity to speak today. I had some prepared notes, but a lot of things have already been said, and I just want to try to clarify a couple of them. The New Hampshire Ambulance Association, AMR, myself, everybody wants to end balance billing. It's not a good way to do business any longer. But interestingly enough, Congress recognized that ambulance services were so unique that they actually kept them out of the Federal No Surprises Act, which is an amazing thing to happen in the first place. They put together two pieces to try and address it: the air side of ambulance, air ambulance, and the ground side of ambulance. Air had a very similar committee that was set up, similar to ground, that was settled. That law is now in place, and there is no balance billing in the air ambulance industry any longer. The committee that Senator Prentice sat on for the ground side is very close to finalizing their recommendations, and we believe as an industry that a federal law will come out that will prohibit balance billing on the ground side as well. It's going to happen sooner or later. What we would like to see from the New Hampshire Ambulance Association's perspective is a better state approach than being force-fed a federal approach. And we worked very hard with Commissioner Betancourt and the Insurance Commission staff, Attorney Heaton, to come up with a solution with the insurers. And unfortunately, we haven't been able to get consensus on that. And I think that that revolves mainly around the difficulties in getting people into network. And I'll use Hollis, Senator, as an example. Hollis is not a network with most of the major commercial insurance carriers in New Hampshire. And they're not a network because there's no benefit to be a network to them other than getting a check. Right now, they can send a bill to a customer for, let's say it's $100 for an ambulance trip. The commercial provider then pays that patient what they deem to be usual and customary. So let's say they pay half, $50. They then turn around and bill the patient for that other $50 that's still due to them. Now, if they were a network, they wouldn't have to do that. But if they were a network, they'd be losing that other $50. And the remaining $50 that it costs to provide that service would be borne by you and I on our property tax bill. Now, that is replicated in community after community after community across the state. And granted, we've heard here that commercial providers only represent about 20% of emergency ambulance bills. But I would argue that emergency ambulances are one of, if not the most important part of a community's health network and protection network, along with police and fire. And the cost of them should be covered by your insurance that you and I pay every month. So Senator Prentice's bill, and hopefully with the amendments that will come, takes the patient out of the middle and stops the checks from being sent to patients, which should never have happened in the first place. It's been ongoing now for over 10 years, and clearly that strategy is not working to get people in network. We believe it's a minimal cost to the commercial insurance payers who are already paying these bills and agreeing to appeals from patients when they underpay. And it recognizes that the carrot and stick approach to get emergency providers into network does not work. Right now, there are literally ambulance deserts in parts of New Hampshire. If you are brought to a hospital in the North Country, let's say in Berlin, you're suffering from a heart attack, need to have a stent put in, there's nowhere up in the Berlin area that's going to do that. You need to be moved to a tertiary care facility such as Catholic Medical Center. It is very difficult and unfortunately not uncommon to have people sit in a hospital bed right now in parts of New Hampshire for hours and in some cases days because there are not enough ambulances that are in network or even available to move you. And that's not the New Hampshire way. I'm a New Hampshire guy, obviously. That's not how we do things in the state. It's not how we're recognized for doing things. We need a solution to that. Ms. Heaton pointed out that Medicaid was increased. Absolutely, it was increased. A big component of what we do. However, it hadn't been increased significantly in almost 20 years. So, we're so far behind the 8 ball now that taking away the ability to balance bill for every ambulance service in the state is going to have a significantly detrimental impact on the ability to continue to provide services. We need a solution. We haven't been able to reach one on our own. I'm hopeful that this bill will help us get to that point.
Thank you. Sure, follow up? Yes, thank you. With regards to the feds addressing the balance budgeting or balance billing, whatever, that doesn't solve anything for you then, is what I think I just heard, right? Because
Well, we don't know what they're going to say yet, which is why we're hopeful that this opportunity to do it ourselves, because they have made it clear that if a state comes up with their own balance billing prohibition legislation, it will trump any federal legislation that comes down the pike. But if you don't have it, you're going to be forced to use the federal side of it.
but this bill doesn't prohibit balance budgeting.
I think the intent, and I don't want to speak for Senator Prentice, but the intent of one of her amendments will be that there will be a prohibition of balance billing, and we would like to see that and support it.
Final question, if I may, Madam Chair. How is this passed on to the taxpayers for those who are not in network? How is that done?
Well, I mean, if you take any community, there's a cost of readiness. It costs, let's say, $1,000 to provide the service every year. They divide that cost of staffing and equipment and vehicles by the number of calls that they do, and that's your cost per trip. In an emergency situation, there's no way for you to have any type of market force leverage with an insurance carrier to go out and say, listen, if you accept a little bit less, Senator, I'll use your ambulance for more trips, like a specialty care doctor, for instance. If you accept a little bit less for this type of surgery, we're going to make sure that we direct all of our patients in network to you for more surgeries so you can make up for that difference. That doesn't happen on the emergency ambulance side. You have no choice. You call 911, you get your local community ambulance. So there's no volume incentive to be had, and really no reason to be in network, because you're going to get what they determine is fair.
Senator Prentice.
Thank you, Chair Bertzel. And I know you're not thank you for taking my question, Mr. Sawaz. And I know you're not from Littleton, but I gave that example of the town of Littleton's fire department with $54,000 over 18 months that have been paid to patients. And they've confirmed that they've been paid to patients. So if that's a $54,000 gap in your budget, is it the taxpayer, the local government, that's going to have to fill that hole?
In their case, I would imagine it would come out of the fire department's budget, which ultimately comes out of property taxes.
Okay, thank you very much.
Questions from the committee? Seeing none, thank you.
Thank you.
Heidi?
Good morning, Madam Chair, members of the committee. For the record, my name is Heidi Kroll. I work at Gallagher, Callahan, and Gartrell, and I'm here today representing AHIP. I know that the bill as introduced is going to be subject to some amendments, so I think I would just, I'm just going to give some kind of high-level remarks and comments and thoughts. So first of all, I want to thank Senator Prentice. She reached out to me yesterday afternoon to share with me some of the thoughts and features that she was thinking about for amendments, that she's working on and still kind of working through. So appreciate that outreach. AHIP and the carriers participated in the extensive stakeholder process that the department convened in the late summer and the fall, as you heard Michelle Heaton describe. There were lots of meetings, and both of the large group, and then there were some subgroups that spent a lot of time meeting as well. So lots of ideas were explored during that process, and some probably more than others. I know Senator Prentice is looking perhaps at one that we didn't delve into so much. We, at the department, we did explore an independent dispute resolution type of model, which is kind of goes with what we see in the No Surprises Act. We also explored a rate setting model, and both of those would have been paired with a no balance billing provision. I will say that in the commercial insurance world here in New Hampshire, rate setting is not something that we see or that has been historically looked upon favorably, but nonetheless, we did look at that type of model that would have essentially mandated the fully insured plans to reimburse at some percentage above 100% of Medicare rates. And that happens in contractual arrangements where we see a percentage, 150% or some percentage of Medicare is a kind of a basis for reimbursing of a service. From the carrier's perspective, a prohibition on balance billing to protect consumers is a very important piece of any resolution, and as is getting providers into the network. My understanding is that the federal Medicare reimbursement rates for ambulance services are under review and are expected to be increased. And when setting Medicare rates, many factors and variables are taken into account. And that's why carriers often use Medicare rates across a broad array of services as a benchmark to work off of. So, as you've heard some here today, ambulance services, and I'm just going to focus on the treat, no transport, and the unscheduled or kind of the emergency transports, are somewhat unique in that they kind of come at the intersection of public safety services and as well as healthcare services. So, every municipality prefers, to have their own ambulance service, and there's not always the best efficiencies there, but nonetheless, that's the model that we have. And plus, we have privately owned ambulance companies, which provide the same services that municipal ambulance services do. And then they also tend to do a lot of the scheduled transports as well. So moving patients from one healthcare facility to another based on the patient's needs. So I think what we focused more on when we were with the stakeholder group that the department convened, more focusing on the treat no transport services and the unscheduled transport. So just to be clear, the treat no transport is when a patient has called for the ambulance. They really, they don't either need to be transported to the emergency room or they decline to be transported to the emergency room. So in some cases, in the treat no transport, some treatment was delivered, but the patient was never transported to the emergency room. And I will say, and I have this later in my comments, that commercial carriers do have a billing code and do reimburse for treat no transport services. My understanding is that Medicare does not cover treat no transport, and in New Hampshire, at least currently, Medicaid is also not covering that, although I know there's a piece of legislation to this year to try to address that as well. So, as you've heard from the conversation, the payment sources for these treat no transport and the emergency transports, payment sources for those services kind of to be standing by and ready, are one of three really, the local, or a mix of the local taxpayers, the insurance payers, whether it's commercial carriers, Medicaid or Medicare, and then the patients who use the service. And so, each of these patients, each of these players, I think, do have a role in helping to pay for the services. But the question always comes down to, how much should each of those players be responsible for? And, I do think that there is some role for the taxpayer to be paying something. People may have differences of opinion about that, but when I think about, for example, fire, we all pay for, the fire department to be on standby in our communities. In the case of if the fire department does have to come to your home, I don't think that the homeowners are getting, or the homeowners insurance is getting a bill that says, well, it costs us this amount of money to be on standby this month, and we only had 2 fire calls. So, you know, you and the other person are each getting 50% of what our cost of being around this month were. So, you know, that's where I'm talking about this kind of intersection between healthcare and also public safety. We learned a number of things during the department stakeholder meetings. We learned that, as was earlier said, the commercial payers, both fully insured and self-funded, only make up about 15 to 20% of the ambulance providers' payer mix. A study in Maine found that that number was under 10% for them. So, you know, we're guessing a little bit here in terms of New Hampshire. The rest of the payer mix is Medicaid and Medicare. And I would say of that 15 to 20%, again, that's what they're calling commercial payers. So that's both fully insured and self-funded. So, you know, perhaps only about half of that 15 to 20% is going to be the fully insured payers. And that's the piece that any state legislation, I think, can get at, because when we have our insurance laws, those are the laws. Those laws apply to fully insured, not self-funded, not Medicaid, not Medicare. We also learned that commercial payers generally reimburse for ambulance services at higher rates than either Medicaid or Medicare. So we are the smallest slice of the pie, but we're reimbursing overall at higher rates. And as Michelle Heaton mentioned, we did have I think a little under $12 million in Medicaid rate increases for the ambulance services in the House Bill 2. Those are 50-50 coming from state and federal funds. So hopefully that should help alleviate some of the pressure. And as I mentioned, we know that we have billing codes and reimbursement for treat no transport. So, you know, I think the predicament that we're in is really attempting to try to figure out where we're collecting the costs from: the payers, the patients, taxpayers. On the balance billing piece, you know, we touched on this a little bit. We do have our current law in New Hampshire that bans balance billing for a number of specialties. And we also have the balance billing ban that's coming from the No Surprises Act. So that is blanket across all providers except the ambulance. When providers do come into network, they have a contractual agreement with the carrier, with the plan. They get paid the contracted rates directly from the carrier. And then our laws do say that if you are in network, you are prohibited from balance billing the patient. So we do think that, you know, solving this balance billing problem is an important piece of any solution that we come up with. We would be concerned, I think Senator Prentice had described to me yesterday when we chatted, one of her thoughts is perhaps having each municipality come up with their own rates. We would be concerned about any lack of, first of all, the rate setting in general. We're not in that model per se, but if we were to go there, not having any caps on the locally set reimbursement rates, you know, if it was basically carriers have to pay whatever that rate is, we would be concerned about kind of cost creep, I guess we might want to call it. You know, purchasing new equipment, hiring more staff, you know, increasing benefit packages, other, you know, we're just not sure what the guardrails would be around gold plating certain items in municipal ambulance budgets. And that could increase healthcare spending and increase premiums. So I think I'll stop there. You know, happy to try to answer any questions. This is a really complicated situation. We've been trying to work for years on it, and we really did participate actively and in good faith with the department's process, and happy to continue working with Senator Prentice and the stakeholders to see what we can come up with.
Thank you, Heidi. Any questions from the committee? Senator Prentice.
more of a clarification. So again, thank you, Heidi, for taking my call and thinking through this with me yesterday. Your feedback's been really important all along. I wanted to point out for everybody that there are 169 transporting ambulances in this state. So not every community has one, but every community has coverage. And the communities decide, this is the New Hampshire way, how they want that delivered. So what becomes, just for a point, because you had mentioned that every community has an ambulance service, they have someone that covers them, but they all don't operate their own, just for the record.
Yes.
And thank you.
Yep.
After we spoke yesterday, I went and confirmed with the Department of Safety what that number was, and I'm sorry I didn't give it to you earlier.
Yeah. Okay, thank you.
Welcome.
Any other questions from the committee? Seeing none, thank you.
Thank you.
We have the last two speakers on this bill, Chief Scott Hunter. And then Sabrina, you're next.
Good morning. My name's Chief Scott Hunter. I'm the chief serving Bedford, New Hampshire. And today I'm here on behalf of the New Hampshire Association of Fire Chiefs. I've handed in written testimony and I'll just highlight a few pieces of that. We speak in support of Senate Bill 407. The bill seeks to require commercial insurance carriers to pay ambulance providers directly rather than pay the consumer, with expectations they pay that the consumer will then pay the provider. And we're really focused on that piece of the bill. A lot of the testimony today has been at the macro level and some of the effects that will have. At a minimum, we advocate that for direct pay to the providers. When that happens, when that check's written to the provider, it lacks efficiency. Our fire department, like many other providers, provides the ambulance services for our municipality. And like all other transporting ambulance services, we bill for the services to offset the costs. By no means do our rates cover the cost to deliver the service. Municipal taxes are needed to cover the full cost. About 25%, 1 in 4 of the reimbursed funds that we receive from commercial insurance carriers are checks written to the consumer. Let me rephrase that. About 1 in 4 of the reimbursements are written to the consumer. We don't necessarily see that amount get to us. This causes confusion for the consumers and the additional step for the municipalities to recover those funds. SB 407 is a meaningful step to help ambulance providers receive reimbursement directly from the carriers. Thank you. That's my testimony, and I'm available for any questions.
Thank you, Chief. Any questions from the committee? Seeing none, thank you. Sabrina, you're the last speaker on this. We got 2 more bills. Just letting you know.
I will be very brief. Thank you, Madam Chair and members of the committee. I'm Sabrina Dunlap. I'm Director of Government Relations for Anthem. I just wanted to say thank you to Senator Prentice and the Insurance Department for convening the work groups. There were a lot of them. I think they were really helpful. As I won't repeat what everyone said, I want to emphasize a couple of things. We do think a ban on balance billing is essential to a path forward. Obviously, there's discussions at the federal level, potentially at the state level. I'm happy to talk more about the process and sort of the whole check going to the consumer issue. The long and short of it is that's who we have the relationship with is the member. And so if somebody has an out-of-network ambulance provider provide service and we receive a bill from the ambulance who's out of network, we will pay a certain amount to that ambulance. And then sometimes, not all the times, they will balance bill the member. And we might not even know the member's been balance billed until the member brings it to our attention. So I'm happy to talk more about that also offline. And I just wanted to mention the municipal issue adds a really complicated factor I'm on my town's governing body, the select board, and so I see the municipal side. I see how complicated it is to run ambulance 24/7. I know not all towns have this service, and I appreciate that it is sort of a segment of healthcare that is especially complicated, in part because you're talking often about emergency services. So I just wanted to comment that I do think, we have many, many municipalities that are in network with us. There are benefits to being in network. It cuts out all of this whole situation with the separate check, et cetera, gets rid of balance billing. So there are many benefits for municipalities and other providers to be in network. So we are continually trying to get more municipalities and ambulance providers in network. I just wanted to point that out because I think that gets lost in the discussion sometimes. But anyway, I don't want to take up any more time. I'm happy to take questions, and thank you very much for the opportunity to testify.
Thank you, Sabrina. Any questions from the committee? Seeing none.
Thank you.
Is there anyone here that has not spoken on Senate Bill 407 that would like to? Come on up.
Thank you, Madam Chair, members of the committee. For the record, my name is Brian Rill, the president of the Professional Firefighters of New Hampshire and a fire captain in the city of Portsmouth. I had wavered back and forth as to whether or not to speak because so many great speakers came before me, but I did want to touch on one thing that I didn't hear mentioned yet, and it's from a very simplistic perspective, which is as a firefighter, it's my bag. I can speak to the simple terms of an issue. I heard a lot about the ability to bill for services offered and the inability to collect on those services, creating a gap that then has to be picked up by the taxpayer. There is an alternative to that. And sometimes the alternative gets put into play, and that affects the delivery of services. And the delivery of services gets impacted through a fire chief or elected government's ability to not downshift costs to taxpayers, but instead decrease staffing or the utilization of antiquated services or equipment. And the delivery of services then gets impacted through that. So if a municipality chooses not to downshift these costs to the taxpayer, they are negatively impacting potentially the delivery of services. We've seen this happen before with budgets that begin to get stressed at the local level. Staffing has had to decrease and delivery of services is affected. So it is incredibly important that we are able to collect from the services provided because our departments very much rely on the revenue from these services. So that's all I would like to say.
Thank you, Brian. Any questions from the committee? Seeing none. Thank you. With that, I will close the hearing on Senate Bill 407. And when Cam is ready, we'll start on the next bill. With that, I will open the hearing on Senate Bill 412 and invite the prime sponsor, Senator Rosenwald. Welcome.
Thank you. Thank you, Madam Chair. For the record, I'm Cindy Rosenwald, representing Senate District 13. And I'm pleased to be here today to introduce Senate Bill 412, which will allow Cedar Crest, which is an intermediate care facility serving children with disabilities and complex medical needs in Keene, to temporarily add 2 more beds for 2 years. As you may recall, Last year, Cedar Crest came to us and said there was a New Hampshire child residing in a facility out of state whose family would like the child to come back to New Hampshire, but there was no bed available. So in House Bill 2, we authorized one additional bed for 1 year. That's going to expire at the end of June. The reason that the legislature needs to authorize additional beds in the first place is that we have had a moratorium on long-term care bed expansion in statute since 1995. Right after we became the first state to close our institution for children with developmental disabilities in Laconia. And since we closed the Laconia State School, we've prided ourselves on the fact that we partner with families to provide the array of services that allow children with complex developmental disabilities to live in their communities. The long-term care moratorium is essential for other reasons too. We've had a decades-long focus on rebalancing long-term care for the elderly and expanding access to the CFI program. Living in the community is what most older people want, and it's also far less costly than a nursing home. And since the majority of long-term care is paid for by Medicaid, cost is an important consideration. The long-term care moratorium is additionally important because we have a workforce shortage that is particularly acute in healthcare. We can't fully staff the licensed beds we already have. Why am I telling you this? Well, some of you have heard that what Cedar Crest really wants is not just 2 more beds, but to be exempted from the moratorium entirely and to double in size. And I am here to beg you not to go down that road. We don't want to start putting more children in facilities. It's more isolating from families and it's more expensive. And if we start to take apart the long-term care bed moratorium, next it will be the rehab hospitals and then the counties. And it will be like a game of Jenga. The whole tower will fall apart that we've had in place since 1995. We don't have the workforce for that to happen, and we don't have the money. So I am fully supportive of helping Cedar Crest serve New Hampshire's children with complex needs. And so I believe that 2 additional beds temporarily is appropriate and fair, and I'm happy to answer questions. Thank you.
Thank you, Senator. Any questions from the committee? Senator Prentice.
Actually, I think the question is for you. Do we have representatives from Cedar Crest here? I have some questions.
Yes.
Okay, perfect. Thank you. All right, great.
Seeing none. Thank you, Senator.
So, because I have to leave for an off-site meeting in a few minutes and I have the next bill, I wonder if you could recess this hearing and open the next one so I could give my testimony and then.
We only have 1 speaker on this, but is the committee okay with recessing it?
Okay, if there's only 1 speaker, that's fine.
Let's see how long he takes and then.
Okay, thank you.
You're on the, Jay? Welcome.
We left all the other speakers at home. Good morning. Thank you for having me. I'm Jay Haston, and I'm the president and CEO of the Cedar Crest Center for Children with Disabilities. I'm pleased to be here to chat for a few moments about this bill. We provide exceptional post-acute care and education to our state's most medically and developmentally complex children. Our job each day is to handle incredibly challenging medical, developmental, and therapeutic needs so that these kids can be kids, play, learn, and grow. Specifically, we're licensed as an intermediate care facility that serves the most medically and developmentally complex children and youth. They range in age today from infants through age 22. We are the only pediatric post-acute facility in the state, and indeed in all of northern New England. To give you an idea of that medical complexity, 40% of our children rely on a ventilator to assist with their breathing for all or part of the day, and 100% of current long-term residents use a G or a GJ tube for at least part of their sustaining nutrition. If you are familiar with other nursing homes in the state, you know that it is rare to find a single ventilator in an entire nursing home. We have 10, and we are a small facility. We also provide special education instruction in an approved private school on our premises and provide respite care to give families and caregivers a much-needed break. Our services are not just long-term services. The average length of stay is 3 years or less. We have a variety of stay lengths from a long weekend or recovery from a medical procedure up through folks who are not yet ready or able to be in home care. But the focus very much is on transition. We are there as long as we are needed. We are not there to be a permanent solution. Since the pandemic, the demand for our level of specialized medical support, both short and long stays, has cumulatively increased by 30%. We receive more inquiries per month than we can currently support under our capacity limit. Our workforce is strong and would love nothing more than to provide our specialized medical care and therapies to additional children and families in need. Unlike many other skilled settings, we have staff, specialists, and bandwidth ready to meet this need. What we don't have is permission to serve those additional children, given the sensitivities around the bed moratorium. Families and children are in need of these specialized services, both short and long term, for which we are the only pediatric post-acute environment. Hospital partners and care teams want to discharge these kids to a post-acute environment like Cedar Crest, as this frees up critical beds in hospitals and saves taxpayers money. The bed day cost at Cedar Crest is between 2.5 and 10 times less than what it is in a specialty hospital setting. As we are the only facility of our type, families who cannot support care at home turn to us, trust us, for a break, a rehabilitative stay, for day education, or for a longer term stay. We were incredibly grateful that our bed license was expanded by a bed last year in House Bill 2. That bed has been filled throughout the year, and we maintain a wait list. The House Bill 2 authority expires June 30th, and so we are very thankful that Senator Rosenwald has agreed to sponsor this bill to allow for 2 additional residents through June of 2026. Given the sensitivities surrounding the bed moratorium, we've assured Senator Rosenwald that this is all that we would seek in this legislation, as it addresses the urgent need, reserving for next year the necessary conversation about longer-term complex medical needs and where Cedar Crest fits in that continuum of care. This is a unique population whose needs are well met in our setting, and indeed can only be met in our setting for many families. As the only intermediate care facility for those children, we thank you for hearing this bill and urge its passage as introduced. Thank you.
Thank you, Jay. Any Senator Prentice?
Thank you, Senator Bertzel. Thank you for joining us today. Thank you for taking my question. I actually have 3 of them, but I think they build on each other. So just for clarity and for the record, how many bed days of respite do you do per year?
Oh, great question. It varies year to year. We're currently engaged with 12 families on a very regular basis, 24 families who use us at least once per year. We're probably around 300, 350 respite days.
Okay. 300, 350 respite days total?
Yes.
Out of 365 for the entire year?
Yes.
That's okay. No. Secondly, how many children from other states are coming into New Hampshire and are able to, access a bed?
Sure. So currently, we have 2 children from Maine and 3 children from Vermont. Those stays tend to be shorter in duration. Both Maine and Vermont have settings for older children, so it's specifically infants and toddlers that they lack a post-acute setting for, and those folks tend to have the highest success rate in transitions home. So those stays tend to be shorter. Right now, there are 5.
That's true. And lastly, how many children from New Hampshire specifically are waiting for a bed at Cedar Crest?
Sure. Four currently, although I will caveat that and say not all 4 are ready today. So our referral process is dependent upon a number of medical needs. Might be something like a ventilator wean in a hospital, for other support services to be ready, or for the family and care team to determine what the long-term path is. So our wait list currently has 4 likely admits.
Perfect. One quick. So just for clarification, final, did you say you had 10 ventilators?
That's correct, yeah.
Okay, thank you.
Seeing no other questions, Jay?
Really.
Thank you.
All right, thank you.
Is there anyone here who has not had a chance to speak on 412? With that, I will close the hearing. And when Cam is ready, we will open the next hearing. Right, I will open the hearing on Senate Bill 401 and welcome the prime sponsor.
Thank you, Madam Chair. For the record, again, I'm Cindy Rosenwald from Senate District 13. I'm pleased to introduce Senate Bill 401, which will repeal the sunset date on Medicaid expansion. Currently, the program is set to expire at the end of 2030, and I apologize in advance. I'm going to have to run out of the room as soon as I stop speaking. As you recall, last year, Senator Bradley's Senate Bill 263 repealed the sunset date for Medicaid expansion entirely. The entire Senate agreed with him and sent it to the House with a 24-0 vote. Unfortunately, some House members refused to reauthorize the program with no end date, and we ended up in the budget with a 7-year expansion. But Senator Bradley made a great case for why we should reauthorize the program with no end date, and I agree with him completely. He said, and he was absolutely correct, that our Medicaid expansion program is very successful, and the reauthorization without end date was supported by a broad coalition of healthcare providers. He noted the important taxpayer protections in our program, which include a prohibition on the use of general funds and an automatic shutdown if the federal government ever stops paying 90% of the claims. Senator Bradley also noted the correlation between uncompensated care and higher commercial premiums, which he calls a hidden tax, and I think that he is correct. He demonstrated that Medicaid expansion had decreased uncompensated care, therefore leading to decreased commercial premiums. We know that even without a statutory sunset date, any legislator can file a bill any year to end the program, and if enacted, the department would have to just notify CMS we were discontinuing the waiver, and the program would shut down. I filed this bill because Senator Bradley and all 24 of us got it right last year. I hope we'll stand by our own convictions, the 50,000 plus people on the program and our healthcare providers, and remove the sunset date. Thank you, Madam Chair.
Thank you, Senator. Any questions from the committee? Seeing none. Thank you. Ava?
Thank you, Madam Chair. I will be brief. And funny enough, I promise we did not compare testimony. We both just are going to be giving our flowers to Senator Bradley in our testimony. So for the record, my name is Ava Hawks. I'm the Director of Advocacy for the New Hampshire Medical Society, and we are here in support of Senate Bill 401. Since its inception in 2014, the Granted Advantage Healthcare Program has provided crucial healthcare insurance coverage for a wide range of health services to thousands of our most vulnerable residents, hundreds of thousands of our most vulnerable residents. While the Society appreciates the bipartisan and bicameral efforts during the state budget process last year that resulted in the reauthorization of Medicaid for another 7 years, we echo what Senator Rosenwald and the Prime sponsor said, that we believe Senate President Bradley's legislation from last session, Senate Bill 263, got it right, and that we must permanently authorize the Medicaid program in New Hampshire once and for all. By removing the prospective repeal, Senate Bill 401 would indefinitely authorize Medicaid in New Hampshire, affording peace of mind to countless healthcare providers and patients, ensuring that they will have access to coverage when they need it. For these reasons, the Medical Society asks the Senate Health and Human Services Committee to recommend ought to pass on Senate Bill 401, supporting the continuity of care for our most vulnerable residents and to prevent future disruptions in the provision of this vital healthcare program. Thank you, and I'm happy to take any questions.
Thank you, Ava. Any questions from the committee? Seeing none.
Thanks.
Alan Hartford? Welcome.
You can't teach an old dog new tricks. You see that? So I'm Alan Hartford, radiation oncologist, formerly the section chief and also program director at Dartmouth-Hitchcock, retired at this point. I should have mentioned in my prior intro, I also sit on the New Hampshire Medical Society Council, and I am representative for New Hampshire to the American Medical Association, along with one other delegate. Very briefly, there's no reason for this provision to have a finalized date on it. It should be indefinite, it should be permanent. From providers' points of view, whether you're talking about physicians, others, hospitals, stability in the system is very important. There's reliance on this funding. From a patient's point of view, if you have a 7-year cycle and you're in year 1, that may not be too worrisome. But if you're in year 6 and you have a chronic condition which is going to require a year or two of very expensive care, you're already on Medicaid, you have very few resources, you're looking at bills of tens of thousands of dollars a month. The idea that at that point in time Medicaid would disappear simply frightening. So speaking very strongly in favor of sunsetting the sunset.
Any questions from the committee? Seeing none. Last speaker, Jake Berry. Welcome.
Sorry, thank you. Jake Berry from New Futures. Sorry. If you'll recall, last year we appeared before you along with many other organizations, families, individuals, and others pushing for the permanent reauthorization of Medicaid expansion. At the time, we discussed extensively the dramatic impact that this program has had on the lives of the individuals and families it serves since it launched 10 years ago, as well as the billions of dollars that the program has brought to our state to support our healthcare system and our economy. We thank Senator Bradley for his leadership and this committee and your Senate colleagues for your support for permanent reauthorization. Certainly, we appreciate the 7-year extension that was included in last year's state budget. But the fact is that the critical role this program plays in our state hasn't changed, and we continue to believe that the program should exist permanently. The only thing that has changed since last year are the numbers. Currently, more than 58,000 individuals are enrolled and receive their health coverage through Granted Advantage. The total number of individuals served over the life of the program is now at more than 237,000. 62,000 Granite Staters this past year used Medicaid Medicaid expansion to access medical appointments, 31,000 to access mental health treatment, and more than 8,500 to access substance use treatment. And this past year, the program was projected to bring more than $520 million in federal funding here to New Hampshire. We completely understand the need for oversight of a program this large and impactful, but the fact is that the occasional reauthorization battle, even once every 7 years, simply causes uncertainty and instability for our families, our healthcare system, and our economy as a whole. For these reasons, we urge you to pass this legislation to remove the sunset date and ensure this vital program remains in place for those who need it. Thank you, and I'm happy to take questions.
Any questions from the committee? Seeing none? Thank you, Jake.
Thank you very much.
Jake was the last speaker on Senate Bill 401. Is there anyone here that wants to speak but has not been given the opportunity? With that, I will close the hearing on Senate Bill 401. We are going to take a 5-minute recess before we start execing.
Yeah.
Making us up.
So let's, I have a list here. So, I'd like to hold on 354.
Hold on 354.
That's the relative to insurance cost sharing calcs, because I'm not sure,
The copay accumulators?
was,
We've got an
We
amendment.
have an amendment.
There's an amendment. There's an amendment that's being drafted. I don't know. I don't know where it is exactly. I'm assuming there've been discussions between the cancer folks and the insurers, but I think we should hold on it.
So there's another amendment coming?
I'm not sure. That's why I need to make sure.
Mike is nodding his head.
The one I have is 93. Do we have
Yeah,
anything else?
I have
Okay.
amendment 0093.
Yeah, so why don't we hold off?
And that's the amendment that got introduced last week that the sponsor of the bill, Senator Innes, does not support.
Got it.
Okay. Well, I did have a conversation with him and he actually, I believe he was in support, but I want to confirm that before we make a move. 355, Kim, we do have an amendment on that one. It was okayed by the hospital association. Oops, wrong bill, wrong folder.
I have two amendments for 355.
For 355. Okay, anywhere else for Lori? Can't seem to find the bill, but this was an amendment that was put together by Senator Innes and I think the hospital association. HHS. Ben, why don't you come on up and talk about it?
Where's the amendment?
It's in the packet that,
Thank you, Madam Chair. For the record, Ben Bradley, New Hampshire Hospital Association. You may have two amendments in front of you. One is 0077, and the other is the most recent amendment, which I believe Senator Gannon is supportive of.
So the only, are we talking about 355? The only amendments that we have are 0264 and then 0532.
it should be in your package.
Yeah, Ben, did you say Senator Gannon? Oh, I see. I understand. I'm sorry. Forgive me. This is the newborn screening. Okay.
Amendment 532.
532. I had that.
There's a short paragraph. Thank you.
And you're in support of this?
Yes.
Okay. So basically what this does is DHHS shall provide information to the importance of the early detection of CMV through New Hampshire Newborn Screening Program and include an update on targeted newborn CMV screening in New Hampshire. And I think this is a good step towards bringing the acknowledgement of CMV.
And this is a replace all.
Correct. All right.
Thank you, Madam Chair.
Do I hear a motion? I move ought to pass on Senate Bill 355.
I'll second.
I'll move amendment 0532S.
Second.
Any discussion? All those in favor of amendment 0532S, say aye.
Aye.
Opposed? All those in, I'll move ought to pass as amended.
Second.
All those in favor of ought to pass as amended on 355, say aye.
Aye.
Opposed? Consent? Move consent.
Second.
All those in favor of consent, say aye.
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 And I will take it out. 403, we want to wait till the 14th, I think, on this one, from what I've heard. 404, relative to expanding childcare professionals' eligibility for childcare scholarship program.
I move ought to pass,
I'll second that.
and I have an amendment.
All those in favor of ought to pass on 404?
I have an
I
amendment.
thought there was an amendment.
I have an amendment.
Don't we have to pass?
No.
Oh, okay, sorry.
Motion.
So I'd like to move amendment 0364, speak to my amendment, and ask the department also to speak to the amendment, if I may.
All those in favor of?
Second, yes.
So just briefly, I just want to thank the department for digging in on this. The amendment that you have before you is a pilot program. I think this is a really important issue. Folks may have seen the Fiscal Policy Institute report recently about this cliff that we're going to be experiencing in the childcare sector because of the pandemic aid ending. One of the policies that have worked in other states that was even recommended by the Fiscal Policy Institute is trying to support childcare workers who have children in childcare. So that's what this pilot does. We want to know what the costs are. Many of these folks already qualify for the scholarship. So this is a small group of folks qualifying for the scholarship. And I would welcome DHHS to come up to speak to it more because that's where my expertise ends.
All right, come on up.
Good morning. Karen Hebert. I'm the Director of the Division of Economic Stability at DHHS.
And Brian Clark, I'm General Counsel for DAS.
So thank you, members of the committee, and thank you, Senator Whitley, for bringing this topic up. I think it is really important that we try to address many different approaches to strengthening childcare in the state. And we are embarking on a number of different strategies, and this is just one of them. And I think it's an important one. It has a lot of support from the childcare community and from childcare providers specifically. But running it as a pilot will give us the opportunity to really capture some important data to really understand the effects and the outcomes of this particular strategy. So I'm happy to answer any questions, unless you have anything else you want to add.
I'm also available for questions.
Any questions from the committee? Being none. Thank you. All right. All those in favor of
0364.
All those in favor of Amendment 0364, say aye.
Aye.
Opposed?
I move ought to pass as amended.
Second.
All those in favor of discussion?
Yeah, I would just say I appreciate what the department has come up with. Obviously, this bill will go to finance. I encourage the sponsor and the department to continue to look at the numbers in the bill because they are, they've got to be taken in context with the overall appropriation bills that we're going to have, some of which we will get to shortly.
All those in favor of ought to pass as amended, say aye.
Aye.
Opposed?
Consent again?
Second.
Second.
All those in favor of consent, say aye.
Aye.
Opposed? Senator Whitley, would you like to take?
Love to.
Okay. So the next one we have is, 406. That is, I think, Senator Fenton's bill, and I did speak to his aide today. They are working on an amendment, so I suggest we hold on this.
Okay.
Senate Bill 410. establishing mental health community and transitional housing fund.
I move that to pass.
Second. Do you have an amendment?
I do.
Okay.
So for the purposes of conversation, I would like to move Senate Bill, or I would like to move Amendment 0456 and speak to my amendment.
Second.
So you have before you an amendment that the community mental health centers worked on with the department, I believe. Again, just as a reminder, this bill is necessary to implement requirements that the department have made for the community mental health centers to have a certain amount of beds available in this housing space. This was left out of the budget. I'm not sure inadvertently, but it was left out of the budget despite that requirement. And this is what we are hearing is necessary from the CMHCs to accomplish that goal, get to mission zero. I just want to make I would move a committee amendment on 0456 on line 13. Cam, you ready? On line 13, I would like to delete and contracted programs. On line 19 and 20, I would like to delete and contracted programs. And line 27, delete and contracted programs, just so we are essentially limiting to those programs run by the CMHCs because they are the ones that have the requirement and are having those shortfalls.
Senator Whitley, what would the third location where it is?
Line 13, line 19 and 20, and then line 27.
Okay. So all those in favor of the committee? Oh, sorry.
Just a quick comment, I guess, with the 3 deletions, and I'm in favor of that. I would ask the department to re-examine the cost implications and be ready for those questions in finance if eliminating and contracted programs might lower the cost. Thank you.
All those in favor of the committee amendment, say aye.
Aye.
Opposed?
I move out to pass as amended.
Second.
All those in favor of ought to pass as amended on 410, say aye.
Consent?
Second. All those in favor of consent, say aye.
Aye.
Opposed? Senator Whitley, would you like to take this out?
Love to.
Okay.
For Madam Chair, Senate Bill 411, all of the stakeholders graciously continue to meet and have robust conversations. And many thanks to the Department of Insurance for convening those.
Yeah, I apologize. I have talked to the commissioner and he will have something ready for us on the date that we agreed in March. So we'll hold on that one.
Great.
And my understanding is on 455 is Senator, oh, you're still working on that, Senator Prentice?
Yes, I actually just got the incremental percentage changes from Henry Littman yesterday, so I need to take them and put them in a format for OLS to bring in.
Okay, correct. So we'll hold on 455. Next one is 456. Relative to establishing a nurse retention school loan debt relief program. And there, I'll second.
And I would like to introduce Senator Gannon's amendment, 0283.
We have 2 amendments. We have 0283 and 0077.
Hold on. I'm behind the 8 ball here. 456.
They're both Senator Gannon's amendment, 10077 and 10283.
And the latest one is 0283S.
And I think, last time we discussed this, we were interested in hearing about what the actual appropriation was going to be, because it only said $1. So we wanted to hear
Ben, do you want to come on up and talk about it?
I'm having a hard time hearing.
Oh, excuse me. So, with 0283, we had this conversation and we were interested in hearing more about what this would actually cost, because the appropriation was only $1, but we heard testimony from DHHS that it was going to be significant.
I think it will be, but yeah.
I think that's up to the legislature to determine what they would like to appropriate for this program.
Ben, can you speak up a little?
Sure, Ben Bradley with the New Hampshire Hospital Association. I think it's up to the legislature to determine how much they'd like to appropriate to this program. What this bill does is establishes the program and the fund, but it would be up to the legislature to determine what they'd like to appropriate.
And I think this is probably a better conversation that we have in finance. Yep.
So, what I do want to sort of hear more about is the impact on SLRP. SLRP is so important to our providers. I don't want to take away from that or diminish that program, and I don't know who can speak to that.
May I speak to that?
Yes.
Thank you, Madam Chair. So my understanding, and you're welcome to speak with the department as well, the existing state student loan repayment program puts nurses on the third tier of beneficiaries for that program. Additionally, my understanding is that there is currently one nurse that participates in that program statewide, rural and otherwise. And so this program would be outside of that. I understand there were some concerns potentially raised about the competition and ensuring that the existing state student loan repayment program continued to have some advantages to attract a workforce to our rural and underserved communities. And I believe that the amendment before you does that.
Thank you. No, I would just wanted to hear from the department as well.
Good morning. I'm Abby Rogers, Legislative Liaison for the Division of Public Health Services. Just here again to say that we still have issues with no appropriation for the bill. That's a really big problem, I think, for our program, certainly. And then the other piece is we are concerned with any competition with SLRP. We have mentioned that in our testimony. So those are just the two comments I'd like to make today. If you have any questions, I'm happy to answer them.
Yeah, I feel like there's a lot of work done on a number of other bills regarding getting the appropriation right. I think policy-wise, I have concerns about the play with SLRP, and I think it's hard to understand policy-wise whether we need this without having that amount in there. So maybe we do want to hold for further conversation.
Abby, I just have a question.
Sure.
So why is only one nurse, since we have such a shortage of nurses in this state, why is only one nurse participating in SLRP?
So I don't work for the program, but my understanding is we really do focus on SLRP more for physicians. So that the focus is really more on those physicians that need to be placed in rural areas. And that's the information I have. I can get back to you certainly on that. I think it may be a federal requirement to focus more on physicians, but I'm happy to let you know after this.
Thank you.
Sure.
Senator Bradley?
Well, if the consensus is to hold on this bill, I hope that the department will work with Senator Gannon on addressing the issues that you have, because I think the fact that only one nurse is qualified for SLRP. That's why this bill is here. So I'm okay with holding it, but it's gotta be fixed. Senator Gannon has been willing to compromise at funding it for $1 to get it created so that he can, work for this in a future budget. I think we all know we have a problem. So I'm okay with holding, but I'm
Sure,
not
we'd be happy
okay
to reach out to him on that.
not passing this bill either.
Okay, thanks so much.
Senator Whitley.
Abby, have you seen this amendment?
Is it the one from today?
0283?
I have not, no.
Okay,
I just walked
so
in.
if you don't mind taking a look at that and giving us a sense about what an adequate appropriation would be, I would find it hard to vote on this without that cost. So if you could
Sure.
provide that. And then I think there are folks from the of QHCs maybe that would want to provide input on the play with SLRP.
Yeah, thank you. I know one of our concerns was having some funds up front for startup for the program, which is significant as well. Thank you.
Would you like to come up?
They can pull the mic a little closer so we can hear them better.
True.
Did you say move it closer?
Yeah,
Yeah.
Thank you.
just pull the mic a little closer to you.
There you go.
Right.
Good afternoon. My name is Christine Stoddard, and I represent Bi-State Primary Care Association, and we work for the federally qualified health centers that benefit from the state loan repayment program. So one of the reasons why there could be only one nurse is because SLRP is only for medically underserved areas. And the reason being is that it is very hard to recruit people to medically underserved areas. So if you give them the benefit of having the state loan repayment program, they're more likely to come. The other reason is they might not be applying, and that is because the federal student loan repayment programs student loans were just turned back on. And so they could be in this process where they're just having to make their payments again and they haven't applied because the burden hasn't hit them yet. So there's a number of reasons why it could be happening, but we are concerned because we have such a hard time recruiting people that if organizations outside of medically underserved areas are also able to dangle this in front of practitioners, that we wouldn't be able to recruit nurses at all. And right now, just 10 of our health centers have 131 vacancies, including nurses. And it's not to say that we don't want to pit healthcare providers against each other at all. But SLRP exists for a reason, and it's because it is very difficult to get people in rural parts of the state, in parts of the state where there aren't enough providers to begin with. And we don't want to encourage people to have to travel because they can't access healthcare services in their local communities.
But isn't that a reason why we need to expand for the nurses? Because if you've only got one that is receiving it, and nurses provide services that probably the doctors cannot in underserved areas, and we need them up there just as well.
We do, and I guess I would argue that organizations outside of medically underserved areas are more likely to be able to afford in-house loan repayment programs than organizations in medically underserved areas. Not to say that they don't need assistance, but one of the things that we would suggest doing is not only looking at the preceptor programs that are included in Senate Bill 403, but increasing the amount of funding that is in SLRP, because it's my understanding that that budget line is very low right now, in part because student loans were turned back on by the federal government. So you could increase the funding to the existing programs and then also support nurse training programs, because what ends up happening is we can't get nursing students. We have to artificially limit the amount of nursing students we have because they can't then get trained after they graduate because we don't have enough nursing preceptors. And so those are the people that are training nurse graduates. So it's a very complicated issue that I don't know there's one answer to, but there are a number of things that we would support you doing, like increasing the amount of funding in SLRP.
But if we increase the funding to SLRP, wouldn't more physicians be eligible for it versus nurses?
No, it's actually, they don't prioritize one provider type or over another is my understanding. It's really based on the amount of funding that's available at the time the person applies. And sometimes the state requires that providers fail first at a federal loan repayment program before they can access SLRP. So that's another thing that we could consider, eliminating that requirement, because the cycle of loan repayment at the federal level and the loan repayment programs, it likely takes up to a year to fail at the federal level before you can apply for the state loan repayment program.
Okay. Senator Bradley.
You know what, I would ask that the department and other folks like yourself work with Kate to try to come up with, you know, a rational compromise that works, because the SLRP program right now is going to doctors. That's why there's only one nurse, and that's unacceptable.
Senator Bradley, it's open to many providers, including dentists, behavioral health providers, but it's not open to bachelor level providers, which is another issue that we have. So if you have don't quote me on this, I guess you are, but I don't know that bachelor level nurses can access SLRP, and that's a really good question because that's also a limitation. But the great thing about SLRP is that it's very flexible. We can fix it without having to have statutes changed.
And I just want to see something that leaves this committee that addresses the nurse shortage and try to help people and be able to recruit, especially in underserved areas. So
great.
I'm asking you to work with Kate.
We'll be happy to do that. Thank you.
All right, so we are going to hold on Senate Bill 456 till next week, hopefully. Okay. List. And 455, we're going to hold on. Senator Prentice?
Yes,
Okay.
that is the orthotics and prosthetics increase, and yes, I did just get yesterday from Henry Littman forwarded me the incremental considerations that we'd asked for, so I just need to draw that up in the document with OLS and bring it back to the committee. Thank you.
Okay, I think next on the list is 457. That is regards to inpatient psychiatric services authorization utilization review. And I would move interim study.
Can I see an amendment to that? Before we second that, there was a proposed amendment that was sent from the from Dartmouth, I forget. There is a proposed amendment there addressing this problem.
At 8:54 this morning, yep.
You don't have it?
So let's hold on, I mean, if you don't mind, Madam Chair, hold on that. Did you get that also?
I did. I'm going to forward it to Cam right now so you can go through.
Do I need to withdraw my second?
Yep, and I'll withdraw my motion. Okay.
You're gonna hold it?
Yep. Cam, can you try and get your hands on that amendment?
Senator Prentice just sent it to Cam to send to the committee.
In his hands.
Senate Bill 496, directing the Department of Health and Human Services to establish a climate and health protection.
I move on to pass.
Second.
I have an amendment.
Oh, yeah, sorry. There is an amendment 0272S, correct?
Yes. And I would want to, sorry. And I would want to add a sentence to it that, in the absence of, grant funds or federal funds, the department would not be required to move forward with this initiative.
I would also add, Senator, if you'd be amenable to, it says state fund, I mean, right now you have state funds shall not be appropriated to the department for the purpose of administering the program. I would propose, comma, if federal funds are available.
Yeah, but then that puts it back on state funds.
Exactly.
No, state funds shall not be appropriated to the department for the purpose of administering the program if federal funds are available.
Right, but if
Yep.
federal funds are not available, then state funds would be appropriated, right? Is that your intent?
It could be that we pass it with that language and then look at the appropriation in the budget cycle next year.
What was the language that you said in the absence of?
In the absence of grant or federal funds, the department will not be required to move forward with this initiative, something like that.
Cam, you got that?
Will not or shall not?
Will and shall are the same.
Are they sure?
Think so. That's fine.
Yeah, I mean, I would appreciate maybe if we could get an amendment from OLS rather than doing all of this, because I would like to add that. I mean, maybe we need more conversation about this. I haven't seen the proposed language from DHHS.
Sure, we can hold it for a week.
I'll hold this
All
one
right,
for a
so
week.
you'll get that drafted. Thank you.
And if Senator Bradley, if you don't mind also working with the sponsor to this bill as well. I don't think she was included in those conversations.
So we don't have to undo our second motions or anything like that.
So I didn't hear a second, so I heard Senator Bradley withdraw, so
Yeah.
we withdrew there.
All right. Senate Bill 499.
I move on to pass.
Second. All right. And we have an amendment, Bradley Whitley special.
I move the Whitley Bradley special. 0509.
Not what it says.
I know. Kate, I tried, Kate. The amendment is 0509. And I'd like to speak to the amendment.
Okay, go ahead.
Thank you. I want to thank the Department of Health and Human Services, the Department of Ed, Senator Bradley, and of course, Kate Lippman for working very hard, and Jenny Horgan also for working very hard on this amendment. Several of the very costly items were created into pilot programs to target those very, very neediest districts. So if you remember, there was significant cost associated with the breakfast after the bell program and the community eligibility. So we just limited those programs to those schools that were in most need, the highest level of poverty, the kids that had the most kids eligible for free and reduced lunch. So of course, no one gets everything that they want. I want to feed every hungry child, but I think this is a really good start, particularly in the non-budget year. And I want to thank Senator Bradley for his work on this.
Yeah, thank you. And thank you, Senator Whitley. So I just want to go over what this amendment actually funds. It funds the summer program at about $650K. The EBT for those with disabilities at about $75K, and then the school program at about $500K. So that should be in the amendment. I appreciate Senator Whitley's willingness to work with me and to, I think, a large extent, do the work of the Finance Committee in Section 5 to create the funds and appropriate a dollar and allow what I'm sure will be a robust discussion in a future budget from, all of us. I would say this, we've heard a lot of testimony about this. There's a lot of federal statistics that actually rank New Hampshire quite well vis-a-vis other states in the level of childhood hunger. That is something to be proud of, but as Senator Whitley and others would remind us, there are still a number of children that are hungry in New Hampshire, and this bill starts to address that. And I think that's important. I think we need to do it in a approach that's rational and affordable. I also think it's important for those advocates in New Hampshire that have different statistics to examine how they came about those statistics, because it doesn't help the process of producing good legislation when statistics are inflated. And I hope the people in this room take that seriously, because if we're going to fight for this kind of funding, we need to be on the same page as to what the scope of the problem is. So that's my soapbox speech.
All right, so the motion is,
On Amendment 0509S, I heard a motion by Senator Whitley. I didn't hear a second.
I second it.
Okay.
Yeah.
all those in favor of Amendment 0509F, say aye.
Aye.
Opposed? All those in favor of ought to pass as amended on Senate Bill 499, say aye.
Aye.
Opposed?
I'll move consent.
Second.
All those in favor of consent, say aye.
Aye.
Opposed? Senator Whitley,
Apparently Senator Bradley doesn't want me to talk on the floor about anything.
The problem is, and I know I sort of was a little curt to Senator Prentice last week, but committees are meeting after session. So yeah, we're trying to, dealing with 300 bills, we have to deal with 300 bills. So I apologize for that, but it is
No.
what it is.
I thank the committee for their great work on this. It's very important. We should all be proud of it.
all right. 500, I think that's a hold till next week.
Yep.
And 588, I think we have to hold. I know that Senator Lucas Folk is out of town.
Yep.
And I need to discuss her amendment with her.
Okay.
559, relative to the definition of vaccine for purposes of New Hampshire Vaccine Association.
I move out to pass.
Second that. Okay. All those any discussion? Okay. All those in favor of ought to pass on 559, say aye.
Aye.
Opposed?
Aye.
Consent?
No. Can't,
Wasn't unanimous.
it wasn't unanimous.
Sorry. Didn't hear.
Okay,
Take it out.
okay. All right. Oh, I already said that one. Okay, so there, the two that we heard today, 561. Any stomach, that was Senator Rishardi's bill.
I move a second.
Okay. That answers my question.
And she has an amendment. I'll move amendment 0526.
Second.
All right. Any discussion? Although, oh, sorry.
I was just gonna say kudos to Senator Rishardi for herding all of the various stakeholders.
Doing a Bradley Special 2.0.
Rishardi special.
All those in favor of Amendment 526S, say aye.
Aye.
Opposed?
Move out to pass as amended.
Second.
Any discussion? All those in favor of ought to pass as amended on 561, say aye.
Aye.
Opposed?
Consent.
Second.
All those in favor of consent, say aye.
Aye.
And I'll take this one out. And how about 412? Where are we on that one? This is the one, we heard this today, relative to residential care and health facility licensing. This was,
I'll move on to pass.
we don't, the only issue is we don't have a fiscal note on it. I was thinking we would get one by the time it went to fiscal. You want to hold on?
I've had a lot of discussions about this with Senator Rosenwald. I'm not sure I agree with her on her insistence that this only be 2 beds for a temporary period of time. I'm working with a family right now to try to get their child from Massachusetts into New Hampshire. I have a meeting with Cedar Crest this afternoon. I'd like to hold because I think that, going back to the questions that Senator Prentice asked, there's a waiting list of 4.
And 5 are in out of state, and 4 waiting are New Hampshire
Yeah,
residents.
so these are extraordinarily specialized services. So I think that the fear of opening up the bed moratorium is maybe a bit misplaced. So I'd like to hold and pursue this a little further.
Withdraw my motion.
Senator Bertzel, just on the fiscal note, we did get a fiscal note, I think, late yesterday. And it says the department and the Office of Professional Licensure Certification state that the bill as introduced will have no fiscal impact.
All right, good to know. Well, I'm sure Maria will print it out and give it to me. All right, any other discussions on the bills?
No, thank you, Madam Chair.
Motion to move out of exec.
I'll second. All those in favor of moving out of exec, say aye.
Aye.
Opposed? We are out of exec. And we are adjourned.